I want to thank Sasi for introducing me to the society. And so I'm looking forward to playing an active role for Johor. I'm not sure how many members we have in Johor, but looking forward to them. Can you hear me? And yeah, basically that line.
Can hear you very well, strong.
Yeah, good, thank you. Unless anybody got any questions, basically that's about it. Over to you, Mr. Wong. Hello.
Hello, Ravi.
Yeah.
Ravi, this is Danny here.
Yeah, Danny, hi.
Okay, when you had your hormone jab for recurrent,
yes,
did they give you any other stuff like maybe Casodex?
No, nothing. Just the jab. That's it.
Just the hormone.
The Lequin jab. Yeah.
Yeah. Okay. Thanks.
Yeah, that's about it. I mean, I was worried about side effects, but so far so good, man. I mean, I'm putting a little bit of weight, but with regular exercise, I do a lot of brisk walking. I think I'm coping well with it, man.
Yeah. Also, we told you the antidote. Exercise. You'll be
exercise.
fine.
Yeah, that's it.
And you look strong. So. You know.
Thank you.
Ravin.
Yes. Yes.
How's your libido?
Oh, I haven't tried it yet. too worried about it.
Try it.
Try it.
That's your baseline level. At least you know how bad it's going down.
Yeah, I should give it a try.
Okay.
Thank you.
Have you checked with the doctor how long you're going to have this hormone treatment?
They told me anything between 8 months to 1 year. And then after that, maybe take a break for a while and see how the body reacts to it. And then if the PSA still goes up, maybe consider some other options like. I mean, it's quite a far journey, so haven't really thought about it much.
Yes, yours quite safe to consider intermittent.
Yeah, that's right. My glycemic score was 3+4 the last time I checked it. And my PSA, the last reading was 3.7. Relatively still smaller compared to some of you guys. But still a worry, you know.
Worry, yeah. Shouldn't. Worry won't help.
No, just the word cancer is enough to drive you nuts.
Oh, this is a wonderful cancer. Nobody told you.
Yeah, true.
Yeah.
Yeah. Anyone in the group from Johor now?
I'm from JB. I was from JB.
But you've migrated to KL.
Yeah.
I'm from Batu Pahat.
Ah, okay, Benedict. Yeah, great. Yeah.
Who's that? Huh? Benedict.
Yeah.
Batu Pahat, prostate cancer treatment would be a bit of a problem, right?
I'm doing it in HKL.
I see.
Yeah. I already had my operation in December, and now monitoring.
Okay.
And my PSA so far has not gone up. It's still 0.01. That's just a few months after operation.
I see you as B here. What's your name again, please?
Is Benedict Mutusami. Sorry, I was blocked off just now. And hey, thanks a lot, Ravi.
Yeah, thank you.
Can I? Hey, Ravi, is there any questions that you want to ask us or what? Ravi?
No, not really. Just as I told you before, I'm keen to meet up with society's members in Johor.
Okay.
And then I don't think there's a local active club or get together here.
But we have a support group there.
Yeah,
but,
that's right.
We meet once every 2 months, I think. But there's no MCO.
Okay.
And I already put your name into that. I think the guy leading that is I think is here is Ho Tun Tiu. I think Ho Tun Tiu is here.
Okay.
And then the other guy, the one iPhone is Ho Tun Tiu.
I see.
Oh, can you put yourself as Mr. Ho is from JB. He is one of our leaders there, and the other one is who is the other guy? Sorry, I forgot. Naha, is it? Nasa. Never mind.
I thought it's Chua Sing.
Oh, no, Chua Sing also. Yeah, Chua Sing is also he's from
Helping
Malacca,
out there.
but he comes in over and help.
Yeah.
Yeah.
See.
Okay.
All
All
right.
right. So this Mr. Ho is the one labeled as iPhone. And Mr. Ravi, I have already put you into the support group already.
All right.
All right.
Thank you.
Okay, you're happy, isn't it? But I think you would like to know, is there a urologist or oncologist in JB that you can safely consult, right?
Yeah, I'm consulting a urologist by the name of Alan Sim from the Gleneagles Hospital here.
In where? In Singapore, right?
No, in Johor.
Johor.
There's a private hospital that's just opened called Gleneagles here. And this Dr. Sim used to work in Singapore General Hospital. He relocated here.
Okay.
So I have been in contact with him. And he's the one who was telling me that he wants to set up a support group here. And I said, okay, let's see how it goes. I don't think he was aware of this group.
All right. So you're happy with Dr. Sim lah. All right.
Okay, so far so good.
Okay. All right. Okay. Anyway, we live for this Benedict Muthuswamy lah. Hey, Benedict.
Yes,
Benedict.
yes.
Sorry, I was out. So can you briefly introduce yourself, or you have introduced yourself already?
I've already introduced myself.
Okay, sorry.
Now I'm in monitoring lah. December
Okay,
I have operation.
Oh, you're going for operation in HKL.
Yeah, I had it in December.
The operation.
Yeah, it's over. It's over.
Who operated on you?
What's his name?
Asani.
Oh, the Chinese guy.
Warren Low.
Yeah.
Warren Low. Okay. And now, do you have any leakage or not?
Still got lah. Still struggling.
Still got
with it. Yeah. Still struggling with it.
Oh, you said December, so now it's 8 months.
Yeah.
Yeah. Hopefully you recover lah. Don't worry. You are doing Kegel exercise, right? Yeah.
Yes.
Okay. Yeah. I think you do it as frequent as possible lah. Huh? Yeah. Okay. Do you have any questions?
No, if there is a Johor group, I'd like to join. That's all.
Oh, you're from Johor as well?
Yeah, Batu Pahat.
Oh, Batu Pahat. Okay. All right. I'll put you in the Johor group.
Okay, thank you.
All right. Thank you very much. And the next guy, I think we got Agnes. We just now talked to Agnes. Agnes Ho, can you introduce your husband or your husband?
My
husband is Chinese educated.
Yes.
Okay,
It's just,
carry on,
it's just,
Agnes.
it's just, because I just like to find out more information, because even my brother has prostate, but at the moment is a benign.
Yes.
And my husband, he doesn't have any symptom, PSA of about 7 something. And we have actually consulted more of the government hospital, and the specialist told us, don't bother doing frequent tests on the PSA, that it is quite normal for people in the 70s to have this fluctuating due to the lack of testosterone. So we just like to know more before the thing becomes, becomes malignant. So just information they'd like to gather, because my brother, he has his PSA drops after some medication, but my husband is somehow or another not suited to taking any medication, as it causes him to have dizziness and all that.
What medication you're talking about? What medication you're talking about, Agnes?
I can't even remember, because it's already more than 2 years he stopped it.
All right. So how old is your husband? 70 what?
Mid-70s.
75, let's say, huh?
Yeah,
Okay.
yeah.
And his PSA only 7, right?
Yeah, PSA 7.
And he's always 7, right? Around
It
that.
fluctuates between 7 to 7.5.
Yeah. And your urologist say that you're all right lah. That means just watchful waiting lah. You just just
Just
monitor lah.
watching, yeah, they have done
Maybe
the DRE.
maybe every 6 months go and get, or 1 year take a PSA and see how it goes.
But he was saying that it's actually a waste of time. So we just puzzle. Is there any other markers that we should look out for?
Okay, has your husband has any other symptom like urinary problem? You know, when he go to urine, is it a smooth flowing, or has he got any other you know, other symptom?
No,
Like maybe bone pain? No, and
No.
nothing do it.
nothing. He has no other.
Or how about frequent urination in the night? Maybe.
No,
No,
only
not-
once a night. That's all.
I think your husband most likely don't have prostate cancer, hopefully. But
Oh,
Dr.
that'd be
Murali might
great.
disagree.
So
But
what is the what's
I
the
think you are
reason
too careful.
for the?
But I
Yeah.
think I'm more interested in your brother. So call him to phone us. You know how to contact us, right? Call him just like you lah. Join us, and then we will try to help him lah. That's our job.
Yes,
Okay.
yes. If you can put us in one of this support group within KL or something like that.
Oh, where are you from? KL.
KL. Yeah.
Where do you live around?
Shah Alam. But my brother
Oh,
stays in Perak. Not
Oh, in
very,
Perak we have a Ipoh support group. Okay.
but he's not technologically very savvy, you see. So it's more of me gathering the info for him.
Like that.
Mhm.
Is he in Ipoh? Ipoh itself.
Yes.
Never mind. He can attend our support group because there are a few Chinese speaking guys there also. And some of them, we have a translator, don't worry. Yeah. So
Okay.
next time now, when there's no MCO,
Yes.
we invite your
We,
brother to come
we
in.
don't really stay in Ipoh, but actually it's more like Setiawan.
Oh, Setiawan. It doesn't matter. We have a few guys in Setiawan. One of them is the headmaster, Mr. Tor.
Oh,
Mr.
Oh.
Tor, I'm quite sure he can support you as well.
okay.
And Mr. Tor and one big developer there also, Lee Ming Xiong. Yeah, I
Okay.
think a lot of prominent Setiawan guys. We can help you out lah. Maybe
Okay.
if you call your brother. Now, how do you get into this group? I mean, Today Chat group.
I got in this group from another of the, because I was in one of this cancer support group. So it was
Okay,
shared
I
by-
tell you what, you can
Yes.
take a pen and paper. I go and say tell you my telephone number. You call
Yeah,
your
yeah.
brother to phone me lah, and then I call him I call to fix him up to some of the experienced guy in Setiawan, patient like us.
he has no issues at the moment, but just the regular 6 months follow up.
Oh no, he has no symptom. He's okay lah. He's all right. What? Why? You think
He has symptoms in the sense that it's his urination.
he has some blockage lah.
Yes, because he's also diabetic. See, he has all
Yeah,
these
yeah.
things like cholesterol, diabetes,
Okay.
and all that.
Why don't you call your brother to go to, if he's financially okay, just see a private side. One of the private guy in Ipoh. If you want to see the government side also can, you go to Ipoh General Hospital.
Okay.
And if you want us to help you, you can also call us
Okay.
because we know the urology. There's no urologist in Ipoh, but there's a visiting urologist from
Okay.
Kerala. But then
Okay.
Dr. Jamie is a very good friend of ours. He is in charge
Okay.
of all these things. He's a surgeon, but he's in charge of urology lah.
Okay.
But,
Well, why don't I take your telephone number, Mr. Kwan?
012-2786-222.
Oh.
012-2786-222. You mean you call
Okay.
your brother to call me, and then we'll try to fix him up lah. Okay.
Okay. Thank you very much,
All
Mr.
right.
Kwan.
Okay, that's good. Then we have next one is Joshua Ho.
No, we can't
Okay,
say.
go ahead, Joshua.
Agnes' case, you said that her brother was under medication.
Yeah, we don't know
Yes,
what
yes, he's still-
medication.
I can't
So you don't know
remember.
what medication that's important. What medication is it? Is it cancer?
But she
Is
doesn't
it-
know. But anyway,
Yeah,
I think
it's
let's
that's-
stop.
important to check it out.
Yeah,
Yes,
It's important
yes.
to check it out first, you see.
yeah,
Yes.
What kind of medication it is.
yeah. I
Yep.
think
Is it for-
your brother should call me up, and then I see how we can help you lah. Yeah.
Okay. Okay.
All right.
Thank you. Thank you, Mr. Kwan.
All right. Okay. Hey, Joshua Ho. Hey, thanks a lot, Dato.
Hi guys, I'm Joshua.
Hey, can you put your video on so that at least we can see your face, Joshua.
Oh, okay.
All right. You look very young, Joshua.
Yeah, I'm sorry. I joined at the wrong time. I thought this is a talk.
No, it's okay. How old are you, Joshua?
33.
33. I don't think you have prostate cancer, but never mind. Go ahead.
No, I joined at the wrong time.
No, never
there's a
mind. Don't
talk at
worry.
3. But yeah, I'm a medical physicist. So.
Oh, you are a physicist, Oh, medical physicist,
At the RT department. So I do plan prostate
Okay.
cases.
What hospital is that?
Sunway Med.
So your boss is coming in, Dr. Heng.
Today I'm not sure.
Yeah. He connected me just now.
Oh, okay. I guess yeah.
So,
I got
so
this
you
link from
are
her.
working with Dr. Heng, and of course, Dr. Murali is here also.
Oh.
Oh, okay. So you are not a positive patient. It's all right. Okay. Anyway, welcome, Joshua. Okay. The next guy is Koh Heng Fui. Mr. Koh Heng Fui. Hello, Mr. Koh. Koh Heng Fui.
Koh Heng Fui,
Hello?
Raymond Koh lah.
Yeah, Raymond Koh. Alamak.
He's an old timer.
He's a veteran. Anyway, no need lah. Okay, we cancel Koh Heng Fui. And Kumar, Suye Kumar, Mr. Kumar. Suye Kumar, wait a minute. We have 72 in now. Mr. Kumar, are you there?
Ashok Kumar, is it?
He put Suye, S-U-Y-E-Y lah.
This Ashok Kumar also looks new.
Ashok, not that new, but yeah, he jolly welcome. Come in. Wait a minute. Let me browse through everything first. Most of them are. Yeah.
One thing, just to update you, YouTube is already live.
All right. Oh, already live. Okay. Now we have
Already-
74.
I already sent the link to a few sites already.
Okay. How about Khalid Tassan? Khalid Tassan, can you unmute yourself?
Yeah, good afternoon, Mr. Kwan.
Yes.
Okay,
Carry on.
my name is Khalid Tassan.
Hmm.
Okay, I'm from Sungai Buloh, Selangor.
Oh yeah, okay. Welcome.
Okay, so the first time, actually, my history is like this. Actually, I was detected my PSA has gone up until.
Sorry,
5.1.
Khalid, can you unmute, can you put your face, your
Oh yeah,
video?
put your video on. Put your video on, Khalid.
Where shall I? Okay.
Are you using a handphone?
I using my handphone.
Okay, you tap your handphone.
yeah, can also.
Tap your handphone. Let me talk. You tap your handphone, and then after that, you can see at the right bottom left hand there is a video stop video sign. I think it's been crossed. You just tap it, uncheck it, then we can see your face.
Okay. Let me start video, isn't it?
Yes, start video. Yes.
Okay, so I need to uncross the one, isn't it? Am I right?
Yes. Uncross it. You just tap it. It will do.
Okay, we can see you now, Khalid.
Okay.
All right, go ahead, shoot.
Okay. So my name is Kali. Actually, I'm from Sungai Buloh, PJ, Selangor.
Yeah.
Okay, so the first time I was detected, my PSA was gone up until 5.4 in roughly about 6 years ago in Pantai Medical Center. During my medical checkup. Okay, so then I gone through the regular PSA check about every 6 months. Actually, it's about 3 years. It's about below than 7. So then I get some advice from the doctor. That time it's a Dr. Suresh. It's a Pantai Klang. Yeah,
okay.
the urology, Mr. Suresh. Then he advised me go for the biopsy.
Yeah.
So I did biopsy. when
Yeah.
I did biopsies, it was a negative lah.
Okay.
There's a no sign of prostate cancer.
Okay.
So then he put me as monitoring. So I continue with 6 months, every 6 months PSA check. Actually, my PSA is a continue raise. And the one point is already raised until 8 point something lah.
Okay.
So he advised me go for the PET scan.
Okay.
Okay, the PET scan I did at one of the hospital, Beacon Hospital in the PJ.
How much it cost you? Is it it's about 3,000 something or
No, about 5,000.
Oh, 5,000. So it's PSMA lah. PSMA. PET scan.
Yeah, correct. So it's a thorough check on my prostate and other area as well lah.
Okay.
So that result also come out with a negative. There's no sign
very
of
good.
cancer. Yeah, there's no sign of cancer.
Mm.
So I go back to Mr. Suresh, then I show all his report. Then he advised me go to Sunway Medical Center, Velocity, where I referring to Mr. Silva.
Okay.
So
Velocity.
Yeah, then I refer to Mr. Silva. So then Mr. Silva did second biopsy. So the second biopsy came out, I got a cancer lah. Okay, the small portion of cancer in my prostate.
Yeah.
So
How many cause positive? 1 or 2 cause only? You know, samples.
It took about, I know mistaken, 14 sample, I think.
14 samples. And how of the samples? How many are positive with cancer? 1 or 2?
The one, I'm very sorry. I
you don't
couldn't
know. Okay, never mind. Just a little bit lah.
Okay, then he told me that my Gleason score is about 3+3.
3 plus?
3+3.
Oh, very good one. Okay.
Okay, then I will he put me in the active surveillance.
Okay.
So I was monitor every 3 months once. Every 3 months once. Actually, my what do you call, my Gleason score is about 3+3. Actually, my PSA actually raised, you know.
To what?
Okay, it's until about 10 something already.
Okay.
Okay, so this year February I did another biopsy. It's recommended by Mr. Silva after 1 year.
Oh, okay.
Okay, so I did another biopsy at Sunway Medical at the Velocity. Then that one is my third biopsy, consider my third biopsy.
Oh, yeah, okay, yeah.
Then it came out still about 3+3 lah.
Okay.
So he told me there's no increase in the size of cancerous. It's a localized cancer lah. He told me it's a localized cancer.
Yes.
So after that, I got some friend. One of my friends recommended to me go for surgery, robotic surgery.
Yes.
So I went to see Dr. Murali at the Sunway Medical Center, PJ.
Yeah, he's here.
So
Okay.
Yeah, then he recommended to me go for the robotic surgery lah. Okay, on the 11th, I got one appointment with him. So I'll be going for the robotic surgery on the 26th.
Okay.
So actually, I don't want to continue because it's about 6 years, 6 or 7 years. I continue this this kind of follow up.
Yeah. Watchful waiting.
Yeah, still waiting, but it's not. According to my urology told me it's not a very high risk.
Yeah.
I don't want to take this chance lah, actually, in future.
Yes.
So I decided to remove my prostate actually.
Yeah. In fact, there are a few guys here, you know.
But
our treasure is like you, KL.
Yeah, but I don't know whether my decision is correct decision or not, actually.
Well, I don't know. It's up to,
choice.
I think if Dr. Murali say, you know, it's good to operate. I mean, he said, how old are you?
I 52.
Yeah, you are very young. So
Yeah, 52.
I think both ways okay. You can do watchful waiting, but you are worried for so long. And the other thing is get it out, and hopefully everything is okay. I think there are a few guys who are exactly like you, 3+3, and they came out quite okay lah. You know, so I mean, Dr. Murali is here. You know, we trust him. So
Yeah, of course.
Okay, all right.
Okay.
All right.
That's my story about.
Okay, Tali, thanks a lot.
Okay. Thank you, Mr.
And
Guan.
the next guy is Chong Ming. Mr. Chong Ming, just now I talked to you. Okay, Chong Ming.
Yeah.
Put the video. Oh yeah, Chong Ming, there you are.
Yeah.
Can you please introduce yourself, Chong Ming?
Yeah, good afternoon, everybody. I'm Chong Meng. I'm going to be 66 in
Okay.
November.
All
I
right.
stay in USJ 1, Subang Jaya.
Uh-huh.
I was detected in February, not cancer first, but growth on my spine. There are tumor on my spine. They caused me immobility. Actually, I'm now on wheelchair, still on wheelchair.
Mm.
And then during the checkup, then they found my PSA. The time when I first in Beacon Hospital in February, my PSA reading was 928.
928 lah. Mm.
Yes.
Okay.
And there are 6 tumor on my spine.
Okay.
One at the T8 was so big that it pressed against my nerve, so I cannot walk.
Mm.
Okay.
Yeah.
I've done my PSMA planning, and then I have my radiotherapy.
Mm-hmm.
Obviously, I've shrunk my spine because it's not hurting anymore, and I'm now doing physiotherapy to be able to walk again.
The radiotherapy is SBRT lah.
Yes.
Okay. Done by who? Dato Ibrahim.
Yes, Dato Ibrahim.
Okay. Mm.
So it helped on my tumor on the spine. And then, as I said, the cancer is a prostate cancer. The biopsy, I have a biopsy done also. Gleason score was 4+5, very high.
Okay.
The good thing is the urologist said it's not spreading, it's contained. Okay.
Who is the urologist? Who is the urologist?
Siwa.
Oh, Dr.
Also
Siwa.
the same hospital.
Oh yeah, okay.
So I'm on hormone injection. I have my 3rd one just last month. 26, and PSA actually last test was 1.04. So Dr. Ibrahim gave me an injection and also put me on Casodex.
Oh, it's Lucrin and Casodex. Is it Lucrin or some other thing?
Pamorelin.
Tourmaline.
So tomorrow I'm going for my blood test again, see what is the PSA score again. Overall, Dr. Ibrahim have been recommending me either to go for Abitron or chemo if my PSA reading goes up. But I defer it because I say I'm not able to walk yet. Let me walk first. Let me improve my walking, and then I consider both. If my PSA go up, I will see what's the result tomorrow.
Yeah, indeed. You just paralyze your lower half, or you just cannot walk. You can
both leg actually.
Yeah,
both
and then
legs.
you still have you can control your urine or your motion. Can.
Yes. After the hormone jab and the radiotherapy, I'm much better actually.
Do you have any physio to get yourself?
Yes. Yeah. Every month, every week I have twice physiotherapy coming in.
Is there any improvement?
Yes. Now I'm able to walk with my walker already.
Oh, very good. I think the person who recovered is Mr. Das himself. He was not able to walk. I mean, not because of prostate cancer, but I mean, but too long in the hospital. But now he is able to walk with tongkat. So that's very good. So I think you will be. But yeah, indeed, I don't know about the silver case. I don't know whether you are qualified. I mean, good to go for chemo or not. Maybe Mr. Murali can give a slight comment on that. If you go on chemo, is there a danger that his ability to walk is more difficult? Mr. Murali. Yeah.
So, Chong Meng, you have got prostate cancer which is spread to the spine. Isn't that what the doctors told you?
Yes.
Yeah. So, at this stage, the stage of cancer is hormone-sensitive metastatic prostate cancer. That's your stage, hormone-sensitive metastatic prostate cancer. So 20 years ago, people in this stage, we will only give them hormonal therapy. Hormonal therapy means either you take Casodex, you take Lucrin, you're taking some other form of ADT. They are all just considered hormonal medications. So this was a standard of care 20 years ago. But since then, the standard of care for hormonal sensitive metastatic prostate cancer has changed. The whole field has now changed. So most urologists, we already know hormonal therapy itself is substandard. You always have to add something else. So the something else is, enzalutamide, abiraterone, chemotherapy. So it's always ADT plus something. That is now the new standard of care. But so the patient has to discuss with his urologist which does he want to choose, the timing, and then the cost of this treatment. Those are the things that you have to think about.
Yeah, thanks.
So in a nutshell, but the question is, what happens if he choose chemo? Does it impede his walking ability?
So the decision to choose either chemotherapy versus one of these new wonderful drugs that you always hear about, abiraterone, enzalutamide. So how do you choose? Well, chemotherapy, the good thing about chemotherapy is you just have 6 cycles. You have to grit your teeth and put up with it, and it's done. Okay? The cost also is much less than those newer drugs. Those newer drugs, the cost is very prohibitive, and you have to take it for years and years. So this is the thing you have to decide. Shall I take chemotherapy up front while I'm still young, I'm still fit? I just have to go through 6 cycles. The cost is not much. And then I wait and see my PSA. And later on, if the PSA goes up, then I can take one of the other drugs, abiraterone or enzalutamide. So this is how the patients have to choose. If money is not a problem, and you're scared of chemotherapy and its side effects, then you say, no, I don't want chemotherapy. Or maybe some people who are just too old or not fit for chemotherapy, then they don't have a choice of chemotherapy. They have to go and take the other one, the oral medications. But these are, as you know, they're very expensive, and it's usually quite difficult to get them from our government hospitals because the stock is, they've got very few patients that they can afford.
Yeah. The latest development is that we have arrangement with National Cancer Society in which we can get alpitron acetate quite cheaply. Actually, the cost is for those, if you're under full dosage of 4 tablets a month, it's about 1,004. But now I think they're experimenting with 1/4 dose. It means 1 tablet a day. And
so that's generic, is that generic?
Generic, yeah, generic alpitron acetate, yeah, generic acetate, which is quite good price. And if you take a 1/4 dose, where Prof. Alinda is trying to having a trial on that one, and then of course there are some other sources that prove that one tablet eaten with food is also possibly control the disease and then some of our guys are taking that one tablet and they're doing well. So but I think your case is because of your walking, but you try to speedily recover from your walking, and then I think whatever you choose is okay, even chemo, I think. Yeah.
Yeah. Dr. Murali, I'm more worried about the chemo side effect that might contribute to my recovery of my walking. That's why I'm worried.
Yeah, I mean, you don't have to decide right now. In a lot of the studies that use chemotherapy also, most of the studies, they gave the hormonal therapy first, and maybe about 3 months later, they gave the chemotherapy. So the timing you can choose, Abiraterone is good, but abiraterone, you must remember that you have to take it with steroids. So this is not suitable in some people. For example, those people who have got diabetes and things like that. The steroids make the diabetes a bit worse. And you have to take diabetes for long term also. There's side effects of steroids for long term. So some people are scared of steroids. So they prefer not to take abiraterone. They prefer to take something like enzalutamide or apalutamide or, things where you don't have to take steroids. So there's a lot of choices now. 20 years ago, there was no choice. You just get hormonal therapy and that's it. But now you got so many choices. So you have to sit down and think of all the different choices and see which suits you, basically, which suits you and suits your lifestyle, I think.
Yeah.
Thanks. Thank you.
No
Yeah, I
worries.
think, that is because you are still young, 66 years old. And I think the good hint is that you can always wait a few months with hormone treatment, and then you decide whether you go for chemo or you want to go for RT. Yeah, I'm quite sure in a few months you can walk already. Just as determined as Mr. Das. Mr. Das is now able to walk. So, and his one is more severe. Actually,
Mr. Kwan Sing,
Yes,
Mr. Kwan
sir.
Sing, can
Yes,
I
sir.
ask Dr. Murali about Chong Ming?
Yeah.
Is it possible that Chong Ming start with abiraterone first, and then when he gets better, he just add in the chemotherapy?
The sequencing.
Yeah.
Well, initially how these drugs came into practice, we always started with chemotherapy first, and then we say, okay, after chemotherapy, the guy responds, and later the PSA comes up, then we'll give abiraterone. And then after that, after a couple of years, we change our strategy. We said, okay, let's give the abiraterone first, and then when it recurs, then we give the chemotherapy.
Yeah.
So both trials showed that you can do it either way. You can give the chemotherapy up front and then later give the abiraterone, or you give the abiraterone first and later give the chemotherapy. You can do it both ways, and then there are pros and cons to each way. Like people who are restricted in financial, they've got a lot of financial restrictions, then of course the chemotherapy is a better strategy. It's cheaper, it's only 6 cycles, and then you're done with it. You don't have to take anything at all. You just follow up your PSA. When you take your chemotherapy, of course, you will have some decrease in quality of life. But this decrease in quality of life rebounds within a year. That means within a year, you're back to normal. And then if you take the chemotherapy up front, you have taken it when you are fitter, you're younger, you're fitter, you've at least taken the bad medicine first. Then later, if the cancer occurs, then you take the other medicine, which is much easier to take. So there are many different ways of looking at this. It all depends on the patient's perspective, his financial state, his medical condition, family matters, social matters. There are so many things which makes somebody decide which way he wants to go. So the doctor is just supposed to explain to you the pros and the cons of each pathway. And then the patient has to go back and sit down and think about it. There's no hurry, Then, like for instance, this kind of prostate cancer groups, you can ask other people, what's your experience of chemotherapy? What's your experience of abiraterone? That's why you get your feedback from members.
Yeah.
Okay, thank you. But
Yeah,
Dr. Murali, what do you think about Casodex at this moment? I think for Chong Ming case, you think Casodex is just too light? I mean, too.
See, Casodex is a very old drug. We used it 20 years ago. At the moment now, when do you use Casodex? You use it in conjunction with that hormonal treatment, because hormonal treatment, when you start it off, initially, the cancer will flare up, When you initially give the hormonal therapy, the cancer will flare up. It's called a tumor flare. And so if you say you've got some spinal cord lesion, it'll make it worse. So the Casodex is meant just in the initial kind of 4 to 5 weeks, just to dampen the tumor flare. You really don't have to take it long term, although some people do. The main indication for Casodex is just in the initial phase. When you give somebody hormonal therapy, you want to dampen down, or you want to prevent the initial flare of the tumor. And after that, most of us don't use it because it costs money, and people with metastatic prostate cancer are going to need money for their treatment in the long run. So we don't want to waste money unnecessarily when we don't need it in the initial part of the game.
Thank you.
I think what happened if we remove the financial constraint, because just a few days ago we have some sort of a mini forum with Alinda, Prof. Alinda, the oncologist, and she was saying that actually Arpitron acetate, the generic one, if you take 1 tablet, is already in the blue book. That means that the government has already approved and they are willing to finance it. Unfortunately, the implementation part is a bit slow and is subject to one hospital or another. In fact, you might be able to get on one tablet free of charge from that means it is paid by the government. In some hospital, I think the good one to try, of course, is UMMC, where Alinda is holding a trial, something like that. But anyway, don't worry, follow on that. If you have a choice of, but okay, you come back with age, you can do it, nasty one first and then followed by this. But there is a study saying that if you are, you can always, if you are hormone refractory, you can go for RB first, and then after that you go for chemo, and then you go for ENZA. What is your view?
I'm not really sure which study you are quoting, but
what
overall,
study is that, Albert?
I think it's probably it's not a study, it's a kind of like a consensus among a lot of oncologists, whereby when you become castrate resistant, you may go for RB first. The sequencing will be RB first, and then chemo, and then maybe ENZA, or go back to RB, because the chemo may have resensitized you again.
Okay, so now we're talking about a different state. We're talking about castrate-resistant prostate cancer, which is already another couple of stages down the line.
On the road, yeah.
These are really very difficult cancers to treat. And most urologists and most oncologists know that if you use RB, to use ENZA after that, it's like throwing money down the drain, because both drugs are so expensive. And your response to, because RB and ENZA, they belong to the same family of drugs. So if you don't respond to the first one, or maybe you responded and then you stop responding, to think that you're going to get a response to another member of the same drug, most of us would say, better to spend your money on something else. So if you give ABI, no point giving ENZA. If you give ENZA, no point giving ABI. Of course, there may be a few people who respond, but by and large, it is throwing money down the drain. So, you choose one and use it, because there are many other options, and by the time you come to castrate resistant, you need to have a lot of money in reserve, because you need different kind of treatments, you see? And they're all very costly treatments. And that's why we tell people, if you get prostate cancer, treat it early, because it's much cheaper, the quality of life much better. But if you get it late, you can still treat it, no problem. You can still treatment, but it's a bit more expensive. It takes a bit more of drugs and a bit more costly. So you got to kind of weigh which you want, a sequencing, basically, there's so many medication you can take. The question is, which one do you take first? Which one you take number 1, which one you take number 2, which one you take number 3, and how to do it in a very cost-effective manner. That's the art of prostate cancer, really.
Okay. All right. Why don't we move on to another gentleman, Chris Chew. Chris Chew, can you unmute yourself? We can see your photograph, Chris. Chris Chew. All right. Go ahead. Introduce yourself, Chris.
Hi.
All right.
Can you hear me?
Yes, we can hear you.
I have been diagnosed with prostate cancer last year. What happened was it happened gradually. I think about probably 3 or 4 years ago, when the PSA value went up, I wasn't too concerned about it.
For what? Chris, how old are you, Chris?
I will be 69.
Okay. From what value to what value, PSA?
Okay. as I said, I was diagnosed last year. So in 2019, the PSA went up to, I think, about six.
Okay.
But the thing is, it went up rather quickly within the last, the 3 years before that. That means it started with probably 3, 4, 5, 6. That means one digit, one number a year.
Okay.
So by the time when it came to the early part of 2020, then my doctor who is looking after me in other things, he discovered this blood test and then told me you better see a urologist. And that's how it started.
Yes.
So I went to see a urologist, and then
in where? In where?
Do I need to tell where?
No, just what hospital?
It's okay, Chris, because we are all in the same boat. I mean, it's good to share.
Never mind.
No, because I don't know. It's not so much for me. It's whether would I implicate anything.
No, there's
I
nothing
don't want
to
to
implicate.
implicate anybody. I have seen more than one urologist. So
Okay.
I'm not.
All right, go ahead. Never mind.
Okay, so what I did was, after seeing the urologist, then he first, of course, did his so-called digital examination, and then he found something. He said there's something. He told me there's something. So following that, very soon I went for the scan. Then the scan indicated some few parts, So following that, the next course of action was to do the biopsy. This is where I got into a little bit of difficulty, because the so-called conventional way of biopsy, which they just do it, I think, through the
anus.
So I was told that is not the best method. So in fact, I was approached by another urologist to do the super duper robotic. So I arranged for that, and I was about to do it, but unfortunately, it was very near the time when this so-called the COVID issue came about. So it was just about a couple of days before the so-called first lockdown. So I postponed it. But unfortunately, after postponing it, I was so scared to go to any hospital or anything. So I didn't get until in June to get my biopsy done.
Okay.
The biopsy was done, and then it was confirmed that, but I forgot the score, but I knew that it was not very good. It was probably in stage 1 or stage 2.
Okay.
Then I went to see a urologist, and then wanted to do the surgery.
Okay.
Because I was thinking, as what the doctor said earlier on, I was thinking the surgery would be the fastest, shortest, and quickest. So I was about to do that, but then the doctor said that no, you must do a bone test or something like that.
Yeah.
So I went for the bone test. Unfortunately, the bone test came out saying that it went to somewhere else. So then, in order to get,
you mean you went to the bones? How many spots in the bones?
At first, they say it went to one of the pelvic bone, and then one on the shoulder.
Okay.
But eventually, after the PET scan, I did a PET scan, and then after the PET scan, they narrow it down.
The PET scan is what? PSMA, is it?
Yes.
I mean,
It's I don't know. It's the same 5,000 ringgit kind of.
Okay.
So after the PET scan, then the urologist told me it's no good to do the surgery. So he told me no good to do surgery, and so then I was left to decide. So I went to see quite a few oncologists, and eventually I went to the UMSC.
UMSC, okay.
So my oncologist is Prof. Alinda.
Okay.
So then I follow suit with the start off with the what you call hormonal, the Leucrin. So I started my first jab. So
Okay.
until now, I've just taken this month. I've just taken my 5th jab. So it's 1 year anniversary already. It's 1 year ago.
1 year, 1 year, yeah.
Yeah, 1 year ago. After the hormonal thing, then the PSA start to. By the time when I before I take the hormonal thing, I went and do my PSA test. It went up to almost about 10. So which means the period of 6 months, it was actually rising quite rapidly.
Okay.
So from 6 to 7, 7 to about 10. But after taking the hormonal treatment, first it start to drop down.
Yeah.
Stop down. Then I went for the radiotherapy.
Oh, okay.
I went for 20 sessions of radiotherapy at the UMSC, which is actually University Hospital, and in November to December.
So the radio only to your prostate or to the bones as well? Is it the SBRT? No.
It's a SBRT.
Do they radiate the bone? No, they shine on the bones.
Yes. They also cover the pelvic bones.
Okay.
According to Dr. Linda, is quite near there, and so they also, according to her, the treatment cover that. Although well, I don't know. As far as the so-called scan shows, it's a very small one on the bone, on the pelvic.
Yeah.
So they managed to cover it. They managed to design it in such a way that they are able to cover that part. So the radiotherapy, after the radiotherapy session, then of course I continue my every 3 months of Leucrin injection.
Yeah.
And my last visit was actually just last week.
Yeah.
And the PSA has now dropped to 0.03.
Yeah.
So it's been on a descending trend. 3 months ago, it was 0.04. Now it's 0.03.
Okay, I think so. You just have to wait, huh? Wait for the things to come down. And okay, we go to the next guy.
Guan Seng, I got something to ask Chris. Chris, are you in any of our chat group?
Not yet.
No.
Not yet.
But are you a member? I think
No, he's not member.
I'm also not a member. But very strangely, this afternoon at about 1:50, actually somebody posted maybe earlier in my other groups saying that yours. So I came in about 1:50.
Yeah.
So
Okay.
I managed to come in. Yeah.
Yeah. Good.
Chris.
Wait a minute.
Chris, can you get my number? Can you please contact me so that I can send you our membership? My number, I'm Stephen Kong, the secretary. My number is 019
Just give me 1 second.
Those who have not joined our Prostate Cancer Society, can you please join? I think it will be very helpful. I'm the secretary, Stephen Kong here. You can always PM me.
Yeah.
Okay.
Take down his telephone number. Telephone number. Yeah.
019
2247
2247
917 2247 917.
Thanks, Stephen.
Okay. Yeah. Thanks.
All right.
Please join our society so that you all will have more benefit. Thanks.
I think Dr. Murali, you agree that he just have to wait, or you think that he need to do something else?
So with Chris' case, you can see, although you start off with a PSA of 6, that doesn't mean you can predict the kind of cancer you have. Most of us think, well, 5 and 6 must be very low. We can wait and see.
Yeah.
Whereas at the PSA of 6, he not only had prostate cancer, he had already got prostate cancer which spread to the bone.
Yeah.
And that's why internationally, if your PSA is more than 4, you have to take stock of it. You mustn't listen and say, oh, it's only 5, it's only 6. I have seen people with PSA of 6, when a biopsy, they got a Gleason of 10, you know. So the moment your PSA is more than 4, you have to take it seriously, because you never know the kind of cancer you had. Is it a 6, 3 + 3? Is it a 7, 3 + 4? Is it an 8? Is it a 9? Is it only in the prostate gland? Has it gone to the bone? You really don't know, just based on the PSA value. So he happened to have a cancer which is a little bit more aggressive than other people, and it had gone to the bone. And the surgeon was correct, before he operated, he wants to make sure this cancer hasn't gone anywhere else. So he did the scans. I mean, you can do a bone scan, or you can do, now people do a PMSA PET scan, and it showed the cancer had already spread. And so he said, well, no, sorry, it's already advanced cancer, no point going and doing surgery. And then he went to see Adelina, and the standard of treatment now for Chris at his stage, he is hormone sensitive metastatic cancer. Hormone sensitive metastatic cancer. That means early stage but already spread. So the treatment for that stage of cancer is hormonal therapy plus radiotherapy to the prostate. Now, whether you want to add on some SBRT to one side here and one side here, one side there, that is optional. There's really no studies that can give you the answer. So the standard of care for Chris is ADT, that is hormonal therapy, plus radiotherapy to the prostate. The other one, that SBRT to the little spots here and there, that's optional. There's really no evidence at the moment to say it's good, it's bad,
Hello? Hello? Some sort of, he lost his voice. Stephen? Stephen, can you hear? I can't hear. Hello?
I can hear you.
Okay. Yeah. Okay, now, Dr. Murai drop off. Never mind.
No.
Hello?
Yeah. Did you hear what I said?
Yeah, last bit not. But anyway, yeah, I think we have heard you. And maybe we move on to our next guy, okay? I think we have only two more to go. One of them is Bob Lee. Bob, I heard about you, but I have never met you. And can you just unmute yourself and come in, please, Bob Lee?
Yes, Mr. Wong.
Yeah, carry on, Bob.
During the last meeting, I was introduced, and
okay.
I have managed to speak the other time. And by virtue of that, I was very heartened that I got in touch with, first of all, Mr. Denisim. Then after that, it was Mr. Das himself who reached out to me. And I'm very immensely grateful to both of them for having the time and the thoughtfulness to reach out to me.
Yes.
So I've also shared my PSA readings with Mr. Das as well. And now, to summarize, by sometime towards the end of this month, I would be going for MRI scan at the GH in Penang. So I started off having a reading of 3+3 for the PSA, and then for the biopsy. And that was a Gleason score that was given to me, which at first I didn't quite understand what it meant, but I had a very good explanation shared by my two senior colleagues that I mentioned earlier. So now it's just a case of me waiting to do the MRI.
Okay. All right.
And of course, it was through your introduction of my name to all in the group that started off this whole process, for which I am tremendously grateful.
Yeah, it's great. I think they also connected you to see Lee Se Bok, I think.
Yes, that's right. Yes.
That will help a lot in Penang. Okay. I think I'm glad that you're getting along. That's good. Another one is Mr. Ng Yat Man. Ng Yat Man. Yat Man. EENYATMAN. Can you unmute yourself? Ng Yat Man. Hello? Ng Yat Man. Yeah, go ahead and unmute yourself, Mr. E Yat Man. If you're not, I'll call another. Yeah, okay, Mr. E.
Yes.
Come in. Yeah, go ahead. Unmute. Mr. E, go ahead. Hello, Mr. E. Mr. E, you have problem with your sound, huh? Okay, how about this, Mr. Baujit Jah? B.A. Baujit. Baujit, please come in. Baujit, can you unmute yourself? No? Okay. How about Irene? I got Irene's phone here. Are you calling for somebody, Irene?
No, just listening only.
Listening, okay, that's good.
Yeah.
All right.
Just for information. Thank you so much.
Okay, good. How about
Thank
Michael Chang? Michael Chang. Yeah.
Hello,
Okay, go
hello,
ahead.
Mr.
Introduce
Wong.
yourself and unmute yourself, Michael.
Yeah, hello, Mr. Wong. Yes, I have met you before and we have spoken. In fact, my dad had prostate cancer. That's why I was in this group. But my dad have since passed away. So I
sad to hear.
remain in this group to keep in touch and to understand a bit better. Yeah.
Okay.
So anyway, he
Yeah.
passed away not because of prostate cancer. It was something else. His prostate cancer was quite well managed, I would say. However, he passed on. So I just keep in touch to have understanding and to understand better. Thank you very much.
Yeah, condolences to you. And I think how long ago your dad passed away?
I think it's about 2 years now.
2 years, huh? All right.
Yeah.
Okay. All right. We are sorry to hear that your dad passed away. Anyway, let's go to another, see whether we
Before we go away, can I say something to him?
Yeah, please.
Please ask him to check his PSA and all that.
How old are you, Michael? Michael,
I am I'm 55 this year.
Yeah, I think you better start checking your PSA also.
You should ask him, have you checked your PSA? Have you ever checked your PSA?
I had my blood test done. I think the most recent one was about, I think 2 years. I need to go for my full blood test again, and definitely I'll keep a close eye on that because I have been, well, should I say, warned or alerted that this could be hereditary. So one of the reasons why I'm also here to just keep in touch and to know what's happening.
Okay. All right. Hey, thanks a lot. I think
thank you, Mr. Wong.
Yeah, very near to 3 o'clock. I can see Dr. Heng. Dr. Heng is in. Dr. Silva is also in. I think we can really start the next session. Okay. Shall I, Dr. Silva, can you please share screen? Can you share screen, right, Dr. Silva? Yeah, you can share screen. Stephen, can you let
Dr. Silva, is it Dr. Silva Lingam?
Yeah.
Silva Lingam. Put your co-host. Put your co-host.
Co-host and you share screen. Yeah.
Okay, 1 minute.
Yeah, please.
Run away already.
While you're doing that, we welcome Dr. Heng from Sunway Medical Center. Dr. Heng, are you there? Can you please put your video on and put your speakerphone so that we can hear you? Dr. Heng. Heng Fok Kam, is it? Is Dr. Heng Fok Kam, Albert?
Dr. Heng is not Heng Fok Kam.
No, Heng Fok Kam, sorry. So Dr. Heng is not in that yet.
Heng Siu Ping.
Yeah, Heng Siu Ping.
Yeah.
Anyway, she's not in there. That means I thought I got the wrong name. Okay. Let me see. Let me scan and see.
I think it's 3 o'clock. We should start.
I think no. Let me introduce. Wait a minute. Dr. Silva, are you ready? If you are ready, I'll introduce you in Okay.
Yeah, I'm ready. But am I allowed to share screen, Mr. Kwan Soon?
Yeah. You can go ahead.
Yes.
The next show is yours. Yeah, because all we have to do is to introduce you in for those people who don't know. Now, Dr. Silva graduated from University of Malaya in 1992 and served in the Malaysian Military Medical Corps since 1993 until 2014. And now he has a fellowship. Well, he's a very international urologist in Edinburgh, specialized in urology, and was board certified in 2004. Now, he did an 18-month fellowship in Melbourne in uro-oncologist and was seconded to GH for 10 years as a urologist, where he trained in robotic access surgery. I think most likely is together with Dr. Murali, who is, by the way, Dr. Silva, you don't know, your friend is here also, Dr. Murali. Now, he retired from the military in 2014 with the rank of Brigadier General. He then joined UMMC as a consultant urologist and lecturer. Now, he's the past president of Malaysian Urological Association, and he's also very active in many international urological bodies. Now, his critical interest is uro-oncology, reconstructive urology, and robotic assisted surgery. Now, he is instrumental in the formation of our Prostate Cancer Society, was an advisor, and the Blue Cap movement is his brainchild, wherein together with Prostate Cancer Society have completed 3 annual runs. Now, for those who are new, the Prostate Blue Cap movement includes the annual Blue Cap run, which is very well participated, very popular. Normally above 1,200 people participated in the past 3 runs, average, and which aim to promote awareness in men's health and urological cancer among Malaysian public, as well as to raise funds in aid of the treatment of urological cancer. Now, he initiated, this is a very new thing for those guys, especially one of our friend, Dr. Faiza. He initiated the low-dose Bracure in prostate cancer since, I think, 2004. Now, of course, Dr. Silva is now a consultant urologist full-time in Sunway Medical Center. We call it Sunway Velocity Medical Center or something like that in Cheras. And okay, I think without further ado, or biting too much on his time, I hand over to Dr. Silva. And he has been working together with us for many years. Okay, Dr. Silva, all yours, man.
Thank you very much, Mr. Kwan Sing. It's such a pleasure to see you, and I see so many familiar faces. I think I haven't been in touch with many of you for quite some time now, ever since I moved on to private practice. And I'm happy that Dr. Murali, I don't know whether he's still around, but yeah, okay. It's
he attended just because to see you.
Oh, fantastic. Okay, so it's great to have Dr. Murali around as well, one of the pioneers of the robotic surgery in Malaysia. So very much in keeping with what I'm going to discuss today. Actually, all of you, I can see you're very well informed. So basically, most of what I'm going to discuss, you already know. But I'm just going to take you through a journey of what we've been through as far as prostate cancer management has been like in Malaysia. But I'll start off first with a question. I mean, is prostate cancer an important health problem in Asia and Malaysia? This is the question that we always put forward to our policymakers, because at the end, you know, we need KKM, MOH to be supportive of whatever we're doing. And we know that prostate cancer management is costly. So one of the questions that would come back to us is that, is prostate cancer really a problem in Malaysia? If you look at the age standardized rates, this is looking mainly in Asia. Malaysia stands right about 11 per 100,000 population. This was actually in 2012, and that's increased somewhat over the years. If you look at US, it has actually decreased from 120 to 98. But when you look at Asia, it's actually an increasing pattern. And you can see there that many of the developed countries in Asia, like Singapore, Taiwan, Japan, Korea, have pretty high incidence rates, up to about 30 per 100,000. And previously, if you look at the data from 2007 to 11, prostate cancer was somewhat number 5, you know, after various other cancers. But the most recent prostate cancer has been moved up to number 3. So following colorectal and lung. So you can see that the incidence is increasing. So like so many other countries in Asia, in Malaysia, we do see a trend, an upward trend in prostate cancer. And why is that so? So these are some of the postulated reasons for increasing incidence in Malaysia. We are getting an increasingly aging population. Our life expectancy has increased. And you can see from the chart at the bottom right of your screen, the projected increase in those age 55 and above is pretty significant up to 2040. And also the diagnostic intensity has increased. You know, we're doing more PSAs now. People are more aware, not just the public, but also healthcare providers. There's a lot more media attention, especially, you know, when you have Prostate Cancer Society, which is nation-based. And of course, the diagnostic intensity improves with better sort of biopsy techniques and better diagnostic modalities. There's also some genetic polymorphism, intermarriages and the gene pooling. And then we mustn't forget environmental and dietary factors. Obesity has been linked to prostate cancer, and we do see some of these things playing up in Malaysia as well as our diet changed to a more Western sort of diet. Now, what about mortality rate? Well, mortality rate remains high, and sadly so, it remains high in Malaysia as well. Now, if you look at the mortality to incidence ratio, it's as high as 40% in Asia. Compared to worldwide, it's about 25%. In Northern America, it's dropped all the way down to 10%. So we still have pretty much high mortality rates. And you may wonder why. Why are we still having such high mortality rates, even though our incidence rate seems to be low compared to the Western countries? Is it a problem of late detection? That means, are we still having lack of awareness now in the 21st century? Is it hesitancy to screen up? People just hesitant to come forward and screen, even though they have symptoms. And then, of course, we always talk about the male macho attitude, which seems to be more prevalent among Asian men. And then, of course, those who have been diagnosed with prostate cancer, there will be those who refuse treatment, or they may choose to seek alternative treatment, which are not the standard of care, but this may be either traditional treatment or some other form of treatment which they may prefer. And then there's always this question of whether there's a higher incidence of advanced prostate cancer among Asians. This has been studied in several countries, including Japan, and there may be some truth to that as well. Now, if you look at our own Malaysian statistics, this is from 2016, so it needs to be updated. But if you look at the UICC staging, majority of our patients still are presenting at stage 4. That's about 53.4%, So that's pretty high. So more than half of our patients, we are seeing them actually at stage 4. So I think Dr. Murali initially mentioned that though the earlier you detect patients with prostate cancer, the chances of cure, of course, is very much higher, and the cost of treatment is also very much lower. So what we are seeing now is where you have more than half the patients coming at this stage, certainly, the chances of cure will be dismal, and the cost of treatment is also going to increase markedly. So let me just run through a case which I saw actually in the year 2000. Now, this is like about 20 years ago. This is a dentist. It's Dr. GBL. And prior to this, he actually has visited multiple GPs, including surgeons, orthopedic surgeon, mainly complaining of bone pain. That was his primary complaint. He couldn't sleep at night because of his bone pain. And then on further questioning, of course, he had LUTS as well, but this was missed out during many of his consults. And finally, he had a PSA done. After many, many visits to various doctors, he had a PSA done. It was 230. This was 20 years ago. And at that time, of course, the only thing that we had was bone scan, and he had a super scan. So you can see on the image on your right-hand corner, the bone is pretty much black. So that's the extent of his metastasis. So at that time, we only had LHRH, which are the agonists. And at the time, the available LHRH agonists were Leucrin and Zoladex. And he was given Leucrin injection. Symptoms relieved immediately soon after. However, after about 3 years, he had recurrence, and he slowly went downhill from there. And during this period, 20 years ago, there was very little that we could actually do. There there was nothing really much available. Even then, chemotherapy was very difficult to come by, and there was not much information that we had on chemotherapy, nor were there many oncologists who were willing to administer chemotherapy for prostate cancer. So the only thing that could be offered to this patient 20 years ago was just palliative care. So this is 20 years ago. So what were the problems? Was there a lack of awareness? Certainly. I mean, at that time, there were hardly much awareness on prostate cancer, nor were there awareness on the management of prostate cancer. Now, of course, there's an element of late diagnosis. They had to go to many different doctors before he could be diagnosed. And again, there was definitely a lack of option for treatment, especially for treatment of advanced prostate cancer. And since then, the Malaysian Urological Association embarked on various prostate cancer awareness programs since the year 2000. These were nationwide programs, and I think there were many that even the Prostate Cancer Society has participated in. So these were campaigns that were held across the country, mainly to promote education and knowledge among the public and healthcare providers as well on prostate cancer. And at the time, screening was also done mainly on the symptomatic and asymptomatic patients. And from this, actually, there was quite a bit of data that we obtained regarding our local population here in Malaysia. So over here, what I'm showing you is a table on the age-specific PSA of the various ethnic groups, Malay, Chinese, and Indians. If you can look at this table at a glance, you can see that age for age, the Indian patients tend to have lower PSA compared to the Malay and Chinese patients. Comparatively, the Malaysians had lower PSA compared to Caucasians. The next table actually shows you prostate volume. So what you're seeing here is that as age increases, the prostate volume also increases. Yeah, and all these figures that I'm showing you is for in general. These are not prostate cancer patients. This is basically from the community that we acquired during the prostate awareness programs. Now, in general, the prostate volume was actually lower for Indian patients as compared to Malay and Chinese patients. But overall, Malaysians, our prostate volume age for age is smaller compared to Caucasians. We also did a comparison with the Japanese cohort, and actually we fall in between. So that means our prostate volume age for age is slightly bigger than the Japanese, but it's smaller than the Caucasians. These are epidemiological data that actually would be useful for us because we need to know what is normal before we can actually look at the abnormal. So now the question is, are we better off today in the sense that are we able to manage prostate cancer better now that we're going into 2021? Do we have improved prostate cancer survivorship? Are we seeing less side effects from the treatment that we give to patients? And the third question is treatment available to all who need it? I think these are the three main questions that we have to ask ourselves to see whether we have improved over time. From the case that I showed you 20 years ago, where are we today? So let's look at a few patients' journey. This may actually strike a chord with some of you, as some of you have, as many of you have gone through this journey yourself. So this is actually a 60-year-old gentleman who presented with minimal symptoms. He had a PSA done by a GP, which was 5.5. This very same patient maybe 20 years ago may not have had a PSA done, but this time even in general practice, many of them are doing PSA, and it was elevated 5.5, and rightly so, he was referred for evaluation. And digital rectal examination was unremarkable. So when these patients are coming to our clinic, of course, we need to differentiate BPH from prostate cancer. As you know, PSA is not specific for cancer, but it should not be taken lightly. So as what Dr. Murali had mentioned earlier, PSA more than 4 should be investigated. And so we draw back to our clinical exam, history taking, and then investigations. Other than PSA, of course, there are various other investigations that we do. We normally start off with ultrasounds, Euroflow studies. And then, of course, we do have certain tools that we can use to assess the individual's cancer risk. There are prostate cancer risk calculators, there are nomograms that we can use. And the ones that I've highlighted here in red, they are not available in Malaysia, but of course, in some countries, they have been used as well, like genetic markers, molecular markers, even vascular ultrasound contrast agents have been used as screening tools for for prostate cancer. But these are quite expensive and they are not widely available, nor are they in the standard of care protocol. And then the next step is deciding on prostate biopsy. So this is the conversation that your doctor will have with you when you have an elevated PSA. They'll talk about prostate biopsy, the pros and cons of having a biopsy. And this is usually driven by PSA and DRE. So in the past, we didn't have any additional tools. No? The only thing we had was PSA and our findings from a digital rectal examination. But now we have an additional tool, which is the multi-parametric MRI. So some of you spoke about this multi-parametric MRI. It's a useful tool that you can now use to guide yourself as to whether the patient needs a biopsy and also to direct yourself when doing the biopsy so that maybe to improve the accuracy of the biopsy. Other tests have been done like 4K score, PCA3, which is done in Singapore, Stockholm 3, blood tests. These are all markers that doctors can use to decide whether you may be harboring cancer, especially the more aggressive type of cancers, which definitely would warrant prostate biopsy. But those three tests in the bottom, they're not routinely done here in Malaysia. They're also quite expensive. So these are some images of the multi-parametric MRI. So basically what is multi-parametric MRI? It's done in different phases. So this is the T2 phase, the T2 weighted phase, and then you can see the lesion over here on the left side. So it appears black. And that same lesion, when you do it in a different phase, which is the DWI phase, then you can see that it enhances. Huh? Okay, so that's how doctors can confirm and score these lesions. This is the ADC phase where it again appears a bit blackish. So using this, the radiologist is able to give you a score. So they see a lesion there, they can score, and this is called a PIRAT scoring between 1 to 5. Any score which is 3, 4, or 5 usually would warrant biopsy. Now, multi-parametric MRI is a useful tool because it may avoid unnecessary biopsies. In the past, what happened was that everyone was biopsied and it sort of led to some unnecessary biopsies, false positives, and it gives this problem of overdiagnosis and overtreatment. So nowadays, many urologists would recommend multi-parametric MRI, although it's not mandatory to do it. After discussion with your doctor, some doctors would still proceed with a biopsy without multi-parametric MRI. That's fine, but it can be an additional tool for deciding on prostate biopsy. So this patient had a biopsy done, and this was what was found. It's a Gleason 3+3. Only 2 out of 6 scores were positive, less than 30%. The left lobe was free of cancer. Prostate volume was about 30 cc. So this is how we define this is what we would define as a very low risk prostate cancer, meaning that the patient has low volume disease with low grade prostate cancer. So this is something new. I mean, in the past, the pathologist would just report it as a Gleason 3+3 and that's it, But now, of course, our pathologists tend to give more detail in the biopsy. They tell us how many cores are positive, how many percentage of cores are positive, and this is all very important for treatment decision making. So that's when we can actually sit down and discuss with patients on their treatment. So treatment, again, these are the options. Either the patient goes for treatment, which could be radical prostatectomy or radiotherapy. But of course, all treatment will carry some amount of side effects. Or the option of active surveillance, especially in a patient like this with a very low risk prostate cancer, low volume, low grade, active surveillance definitely would be an option. And again, this is something that has evolved over the years. Previously, no one ever talked about active surveillance. I mean, here you are diagnosed with cancer. I mean, are you really going to sit down and wait before you initiate treatment? So that was the question. And of course, over the years, we've had many studies that have been published. Pivot study, the PROTECT trials, all this has shown some rationale in doing this sort of active surveillance. So I think you probably have had various lectures in the past on active surveillance. So this basically means you're delaying the treatment. And in some older patients, maybe you don't even need to treat them eventually, you generally would repeat the biopsy in about 1 year. and then you monitor the patients with prostate exam as well as PSA. Now, this is for those of you who may not have seen this study. This is the PIVOT trial. So it was actually comparing between two groups of patients who were under 75 years old. So this is a younger group of patients with a PSA less than 50. One group was surgery, the other group was no surgery, meaning observation. And the endpoint was basically to compare death rate. One is from any cause and the second is from prostate cancer. And the average follow-up was about 10 years, although the overall death rate was 48%, but many of this was for different causes. If you look at death from prostate cancer, it was only 7%. And this is an important chart. Basically, what it shows is that for low-risk prostate cancer, there's really not much difference between the surgery versus the no surgery group. But there was certainly a difference in the high-risk prostate cancer. So this is where, the thinking started to change. Well, low-risk prostate cancer, maybe we don't straight away have to jump to surgery. We can do active surveillance, wait and see. Whereas in the high-risk prostate cancers, you can't wait. So you need to do surgery because that will affect their survival. So that's how thinking has evolved and changed over the years. But there are some problems to this as well. Like in this patient, you can see that after 1 year of surveillance, the patient became very anxious, because here you are, you're walking around with cancer in your prostate, and your doctors are telling you, look, don't worry, it's a very low risk prostate cancer. But of course, the doctors are not going to guarantee that it's not going to progress, although the studies are positive, but you can't run away from the anxiety. So you can see that the reasons for dropping out from active surveillance is not just because of progression of cancer, but 30% of patients drop out of this active surveillance purely because of anxiety. And we have data coming in from Asia. This is the ACAP data, Asian prostate cancer database, of which Malaysia also contributes data. And from that, we find that overall in Asia, only the uptake of active surveillance is only 5 to 10%, right? Even for the patients where it may be indicated, it's only 5 to 10%. So it's still very low compared to the Western countries where the uptake is much better. Now let's look at another patient here. This is a healthy 65-year-old gentleman with a PSA of 8. Came in again with a smooth prostate, no nodules. Volume was about 30 cc. His biopsy came back as 3+4, 7 out of 10 cause, more than 90%. So here he had pretty much significant cancer, falling in the low intermediate range group, but he's actually active and he wants to preserve his sexual activity. So this is another discussion that normally patients will have with their doctors, because here maybe he may not be such a suitable candidate for active surveillance, but which form of therapy can preserve sexual activity? That's one question and one discussion that he will have with his doctor. So again, the treatment options are the 3, which I've listed here. Number 1 and number 2, I've touched on earlier. Number 3 is something I've added on, which is brachytherapy. So I think Mr. Kwan Sing mentioned about low dose brachytherapy, which is another option for prostate cancer treatment, especially whenever the patient falls into whenever the patient has the necessary criteria for brachytherapy, which I'll go through in a short while. So these are what we call competing treatments. Yeah, so they all give comparatively good results in this type of low risk or low intermediate risk patients. And then in terms of suitability for brachytherapy, basically it would be more suitable for those patients who have PSA of less than 10, smaller prostates, less than 40 cc, preferably the older patients, those who may be not fit for surgery, having a Gleason of 6 to 7, and who are sexually active, as it tends to have better potency rates. So if the patients fall in this group, then, well, the low-dose brachytherapy may be an option. This is what seed brachytherapy is all about. So we put in all these radioactive seeds into the prostate, and it's a form of radiotherapy, except that it delivers much higher dose to the prostate compared to external beam radiotherapy. And this service is available in Institute Cancer Negara. But of course, because it's just one of the various treatment available, there are not many cases that we have done. I think we've done over the years only about 12 to 15 cases. So we are pretty selective in the cases that we do. In Malaysia, I think the majority of treatment given is still radical prostatectomy and radiotherapy, external beam radiotherapy. So let's look at another patient here, Mr. KK, who's a 52-year-old gentleman. So this is a young patient. Prostate volume was about 40 cc at a PSA of 80. Yeah? So here he went through the transrectal ultrasound biopsy, which came back negative. All right. And he also had a multiparametric MRI, which showed one area in the left PZ-TZ area with a Pyrad 2 score. So if you look at that MRI Pyrad 2 score, well, this looks like a benign lesion. But then when you look at the PSA 80, well, something doesn't quite fit. And his TRUST biopsy came back as negative. So therefore, something's not quite right. Yeah. So this patient was rightly referred for another biopsy, a second biopsy, and this is transperineal biopsy. At the time of the referral, the PSA is already 120 nanograms per mil. He had his bone scan done, which was negative. Yeah. So there was no evidence of any metastatic prostate cancer from the bone scan. Now, before I go on to the different type of biopsies, because I think that was one of the things that one of you brought up, I just show you this little simple diagram here, which shows the different zones. So it was McNeil who actually described the different zones in the prostate. So you've got the peripheral zone there, and that's where the prostate cancers normally occur. So the outer part here, peripheral zone. Then you've got the transition zone here, where you normally get BPH. All right, so this is the part that enlarges and causes BPH, very closely related to the urethra. All right, that's the urethra there in light green. And then you have the central zone here. Now, although cancers commonly occur in this zone, but they can also occur in other zones, and they can be anteriorly located as well up here. So when we do a transrectal biopsy, it's easier to sample this area, the yellow zone. It may be harder to reach the more anterior part of the prostate. Right, so that's why sometimes you depending on the location of the cancer, you may actually miss these cancers when you do a rectal biopsy. So this is the various approaches, right? So this is how we do a rectal biopsy. We go through this approach. So that's how you get the sample, right? So obviously, when you have cancer up here, you may not be able to reach it. You can miss it, right? So that's where the multiparametric MRI sometimes can help to locate the location of the suspicious lesions. And then you may want to consider doing the biopsy in a different approach. And so we are very lucky now. We have other ways in which we can do the biopsy. And one is using a transperineal approach. All right. So transperineal approach is where we approach the biopsy this way, where the arrow is pointing through the perineum. All right. And we need to use some special instruments like the stepper here. And then we biopsy this way. So these are the two most common type of biopsies that we're doing today. And of course, I think it was mentioned earlier, the robotic sort of biopsy, which is what we call fusion biopsy. Now, fusion biopsy is a little bit different. It's mainly done to improve the accuracy of the biopsy. So this is where, when we find a lesion on MRI, we marry the MRI with the ultrasound images, and that will give us a real-time sort of target that we can use to make sure that we get the lesion. So that improves the accuracy. Of course, that also comes with cost. It's a much more expensive procedure. Now, the transperineal and the fusion biopsies are usually done under general anesthesia, whereas the transrectal can be done under some form of sedation or local anesthetic. So in this patient, having done the second biopsy, came back as a Gleason 4+4. All right, so it's a pretty high risk cancer on the left lobe only. Repeated scanning, the bone scan, PSMA PET, CT scan were all normal. There was no mets. Yeah. So this patient was actually underwent a robotic radical prostatectomy. I think the surgery was done by Dr. Murali actually. So this is the robotic surgery. I mean, this actually brings my discussion to robotic surgery. Now, many of you may have actually gone through this procedure. For those of you who are new, maybe just a little bit of history. The robotic surgery in Malaysia started in 2004. It was actually pioneered by Dr. Shahabuddin. And after him, Dr. Murali took over with the robotic services in HKL. Right. So actually, the pictures I'm showing you is a setup in Hospital Kuala Lumpur. Now, the earlier system, you needed 2 assistants. Okay, the surgeon usually sits in the console. The console is this one here. All right, and then you have 2 assistants. But with the newer versions of the robot, there's an additional arm, robotic arm, so you only require 1 assistant. So of course, the machine has gone through some evolution as well, and it's a lot more easy and user-friendly now. So if you look back at our history from 2004 right up to 2011, that's the data that I have. The initial robot was actually only in a government hospital. HKL and JB had the initial systems, and these were the number of cases that were done, mainly robotic prostatectomy. And then Prince Court Medical Center started their robotic service in 2007 because Dr. Shabuddin moved on to private practice at that time. And then the machine in JB was transferred to Hospital Umum Sarawak. Around about 2008, they started doing cases there. Right. So right now, of course, there are quite a number of centers which are offering robotic service. HKL, UITM, UPM, and then in private, you have Sunway Medical Center, PJ, and Glen Eagles Medical Center. And there have been quite a number of robotic surgeons who have also been trained. By the way, I'm not trained as a robotic surgeon. It's just an interest that I took up when I was in HKL. But there are many of our urologists now who have actually gone for formal training in Korea, in UK, as well as in Canada for robotic assisted training. So not only the number of robots in Malaysia has increased, but the number of robotic surgeons has also increased. So it's a very good trend. Now, when we started our robotic services in HKL, we had 2 proctorships done. The first one was in 2006. And these were the surgeons who actually came to Hospital Kuala Lumpur to proctor the team in HKL, and it was led by Mani Menon. So Mani Menon, for those of you who may not know, is actually the founding father of robotic prostate surgery from US. He's from this Vaitikuti Urology Institute in USA. They came again in 2007 and did about 40 cases with us. So we had 2 proctorship with the US team. Okay, then moving on to the next couple of slides on what happens after surgery. So this is a question that we always have in our minds as patients. All right, so we go through the surgery, what happens after that? We always worry about side effects, right? Incontinence. Well, incontinence now is very much less compared to before, when this form of surgery was first introduced. And that's because of better surgical techniques, not just because of the robot, but because of better surgical techniques as well. All right, there were certain things like Rocco-Stitch, bladder neck sparing that were developed over the years. And recently, I think more and more robotic surgeons are doing this Retzius sparing surgery. All this helps to preserve the patient's continence after surgery. And then in terms of erectile dysfunction, I mean, the results have been dismal. I mean, a lot of patients have lost their erections after surgery. But now more and more, we have good drugs, like, the Cialis 5 milligrams, which you can take daily. We also have protocols. Yeah, of course, we have Viagra. We have protocols on how we can do penile rehabilitation. So this is something that we teach patients, penile rehabilitation, even before surgery itself. And then they continue to do it after surgery. Now, the other question that we always have in mind after surgery is, what about rising PSA? What we call as biochemical relapse. What happens then? This is an old chart. It's from 2003 ESCO meeting. This is just the natural history of rising PSA after surgery. That means you have done surgery, and then after that, you just don't do anything. You just wait and see what happens. All right. Now, of course, not everyone will have a rise in PSA after surgery. But if you do have a rise in PSA after surgery, and if you don't do anything about it, what happens? So this is the sort of postulated natural history of what's going to happen after about 7.5 years. That's when maybe you might pick up something in the bone scan. And then if you were to go on hormone therapy from then on, it might take another 6.5 to 7 years before you may succumb, right? This is just a sort of a generalized kind of chart. Of course, this can be affected by the kind of cancer that you have as well. Much of it may depend on your PSA doubling time. That's what we call here PSA DT of less than 10 months. But nowadays, when you have a biochemical recurrence after surgery, you can expect a much, much better survival, you know. Why? Because nowadays we can detect the cause of the recurrence much, much earlier because we have better imaging techniques. You mentioned about PSMA, PET scan, MRI, which are additional tools that we can use apart from PSA doubling time. In the past, we didn't have all this technology. We were just depending on PSA doubling time. So we were not sure where the recurrence is coming from, whether it's a local recurrence or whether it's a distant recurrence, right? So now with these tools, we have better diagnostic capability. And then we also have better treatment modalities. You know, we talk about salvage radiotherapy. We have protocols for salvage radiotherapy. We can do these salvage radiotherapies early and therefore maybe even have better survival. And also medical therapy. As you know, there are many drugs which are now available in this group of patients. Right, so now we move on to the last part, which is on metastatic prostate cancer. Yeah. So here I want to illustrate a very pleasant gentleman, SBL, a 64-year-old Army veteran, whom I saw actually in 2008, had a biopsy, Gleason 7. At the time, he was already metastatic prostate cancer, 177. Bone scan again was a super scan. Has good performance status, and he was started on Zoladex somewhere around 2008. And this is how his PSA actually progressed. If you can see between 2008 and 2015. So here we're looking at a span of about 7 to 8 years. This is very different from the doctor that you saw 20 years ago who progressed very fast within 3 years, and then there was very little that we could do. So in this case, he was started with Zoladex, and then his PSA actually dropped down to a nadir of 0.8. But then he kind of defaulted for a while, and then the PSA went back up, and the Zoladex was restarted. And then the PSA reoccurred, you know, after about almost 2 years, went up to about 54. And this period, 2013, Abiraterone was already available. Right. By that time, Abiraterone was the indication for Abiraterone was not in hormone sensitive. It was only in castrate resistant. Yeah. And that time we don't even call it castrate resistant. We used to call it hormone resistant. Right. So even terminology has changed. So at that time, the patient has to be proven to be castrate resistant. Then only we move on to Abiraterone. So he had Abiraterone. He had some response for about 1.5 years, and then his PSA just shot up 1,000 over, and he had a lot of other things. He had local progression of the cancer for which he needed channel TURP, and then he even at one point had renal obstruction, which he needed short-term dialysis and so on. But he actually recovered from his kidney disease, and he was fit enough to be given docetaxel. And he went on for another couple of months to up to about a year, and then he succumbed about 2016. So actually, this is an example of how drugs that were introduced during this period, like Abiraterone, managed to improve the patient's survival. So this is a patient who had quite bad metastatic disease. 2008, he went on to carry on for about 8 years. Now, this is another example. Mr. KK was seen in 2013, also coming with a PSA of 150, extensive bone mets with a Gleason of 4+4. Now, he came in at the correct time. He was actually enrolled in the Latitude trial. So that was the year that we managed to get the Latitude trial in HKL. And I think Mr. Murali was the principal investigator for that trial. Of course, at that time, the first question he asked me was, can you assure me that I will be in the active drug group? So I told him, look, this is a trial and we are all blinded, you know, so we won't know whether you're going to be in the active drug group, or you're going to be in the placebo group. So he was willing to take the chance because during this time, Abiraterone, this Latitude trial, for those of you who may not know, this is a trial where we use Abiraterone earlier in the hormone sensitive group. So the LHRH treatment is initiated together with Abiraterone at the first diagnosis of metastatic prostate cancer. So they were just starting the trial in 2013. The trial was completed in 2016. And that time we were recruiting patients, and luckily HKL was selected as one of the Cural centers apart from UMMC. And this was the first patient that I managed to recruit during that time. And so that was the question he asked, and I said, no, we can't decide whether you go into the active group or the placebo group. But he was very lucky, because when the trial was unblinded, we actually found out that he was in the active drug group. In fact, we already knew because when we followed him up, we found that his response was very good. In fact, all the majority of the bone mets literally disappeared. Yeah, literally disappeared. And he remains well till today. All right, he has some PSA recurrence, biochemical recurrence, but he still remains well till today. So from 2013 onwards, we've been talking a lot about combination therapy. So nowadays, we advise all our patients who come with metastatic prostate cancer on this combination therapy. So it's no more like before, where you just give LHRH alone by itself. Now we talk about combining it either with chemotherapy, or we combine it with some of these novel agents such as abiraterone or enzalutamide. Now, then we move on to another patient here, 68-year-old gentleman presented with large PSA of 12. PSA of 20 actually, just omit the 12. His prostate biopsy was 3 + 4, 50% of the cause were positive, yeah? And now he comes with this lesion in the rib, all right? This is a single lesion in the rib that was identified to be a metastatic lesion. So this is where we have a new concept now we call oligometastasis, right? So this is where you might have less than 4 metastatic spots. And this is something that we discussed earlier in your discussion, where you have a few metastatic spots. Now, in the past, patients like this will be defined as just metastatic prostate cancer. There's no such thing as oligomets in the past. And they would straight away go for systemic therapy. But now, this is a new terminology, and there are options for these patients. So one option, we're getting more and more evidence now of the benefit of treating the prostate in this kind of patients. So they have very few mets. The question is, why don't we treat the prostate? And radiotherapy is the choice of treatment for the prostate, combined with systemic therapy, and plus minus local treatment of the metastatic area. So this is one way that we can approach this type of patients. There are ongoing studies to evaluate the value of doing prostate surgery in this setting. At the moment, we don't have enough evidence to suggest doing surgery in this type of patients, but that probably we have more information in time to come. So in the future, we're talking about personalized therapy. This is where we're going to be using biomarkers, molecular markers, and then identify which patient fits best with which type of treatment. And there are many other treatments which are in the pipeline. As you can see, I've actually listed a whole group of them. These are all targeted therapy. So these are AR, androgen receptor targeted therapies. Abiraterone and enzalutamide, of course, is already in the is already with us. Apalutamide is also with us. Then, of course, you have immunotherapy. All the different so-called checkpoint inhibitors. So we have ipilimumab, nivolumab, pembrolizumab. So many of those are in the pipeline, and then the PARP inhibitors and other emerging treatment. I think lutetium PSMA, some of you may have heard about this. Is being given, I think, if I'm not mistaken, in Beacon, but actually it's still under clinical research. Right. So in conclusion, I've actually listed down all the different treatments which are available. Of course, there's some more which I didn't really touch on, like bone-targeted therapy and things like that. But generally, we have a lot of tools in our hands now, not just for the diagnosis of prostate cancer, but also for the treatment of prostate cancer. But we have to understand this treatment can be supply sensitive. That means it's guided by what is available and the reimbursement. So there are limitations, right? And we always talk about financial toxicity. Right? So this is a real problem. This is a real world problem, right? So we have one is ideal treatment. The other one, of course, is what is available and what is affordable. So this is one study that was done it was spearheaded by, her name has slipped my name. I think it was one of the epidemiologists who did this study, Nirmala Pupali. Yes, that's right. Correct. Yeah. So she did this study, the action study, based in some of the countries in Southeast Asia, looking at this so-called financial toxicity. And you can see here that financial toxicity is a real problem, especially in the lower middle income group. It's not done for prostate cancer, but it's done for other cancers. And this is a real problem that we need to look into. And Malaysia, I didn't show it here, but Malaysia is one of those countries where the financial toxicity is quite severe. So the Malaysian Urology Foundation has established a committee just last year to look into these patient aid programs. We hope to work up something to work together with government and private agencies, as well as negotiate with pharma, and see how we can help patients. And of course, this also will open up opportunity working together with the Prostate Cancer Society as well to assist patients with the appropriate channels in which they can get more affordable treatment. So this may be crowdfunding, organizing fundraising events, and other opportunities that may arise to make sure that whatever treatment is available is also affordable. I think Mr. Kwan Seng and Mr. Das, they are the two pioneers of the Prostate Cancer Society, and they were very much involved in moving some of the activities that we've done in the past. I think Mr. Kwan Seng mentioned about Blue Cap movement. Of course, we have not had many runs in the past ever since I left UM, and I think now because of the COVID, things have stopped. But hopefully in 2022 we can start things moving again. Now that I am back in MUF, hope to get these things started back again. I think you can see Mr. Murali there, Professor Azad, Mr. Das, George Lee, and Shankar. So this was one of the runs that we had in 2017. Seems like such a long time ago, Mr. Kwan Seng, Mr. Das. Right. So I think the establishment of Prostate Cancer Society in Malaysia is a very, very important milestone. A lot of patients I see now, I think some of you may have got my referrals. I always send them to the Prostate Cancer Society so that they can talk to you. And I think a lot of them have given me very good feedback that it's a very important thing for them to be able to talk to other patients, share, and get more knowledge on what the other patients may have gone through. So you are all patient advocates, and I applaud you for that. And I think that is a very important role that you play in the management of prostate cancer. So I think that's also something that is evolved in the management of prostate cancer. It's part of the management of prostate cancer, which is creating the awareness and supporting patients to promote change. So the final take-home message from what I've gone through in the various slides earlier, everything seems to move in the correct direction, right? So we've got better awareness, better diagnostic tools, treatment modalities, better expertise, medications. All that is there in Malaysia, but of course we have increasing financial toxicity. We can't run away from that. So we need to have some partnership between NGOs, association, government, private institutions to overcome this financial toxicity and ensure that treatment is available to all. And I hope this will become a reality in future. It's not yet a reality, but hopefully it will become a reality in future. And with that, I thank you very much for your patience to listen to me. Thank you.
Okay, Dr. Siva, you are free to take a few questions, right?
Yeah, sure, no problem.
All right. I think we have agreement with, I think Dr. Murali is still around, right? Mr. Murali, are you around? Oh yeah, I saw his name. Yeah, is Mr. Murali around? He is. And you were not around just now, Dr. Silva, that he agreed that we are going to work overtime because we will be flooded with questions from everybody. Anyway, okay.
Sure.
Let me read from the chat questions first. The first question is from Stephen Kong, I think. Those have no, that's okay. Colonel Lai, yeah. Hope to come back later. Oh yeah, there's a different one. Okay, now we have from Albert, and he said the patch trial shows that estradiol patch can replace LHRH as ADT for prostate cancer. Benefits of using estradiol patch may include, let me see. Somehow or other I cannot get rid of the pop-up. Maybe. Wait, something wrong with my scan. Hey, can you, Albert, can you ask a question because your question.
Okay, I'll do it.
All right, go ahead.
Dr. Sivalingam.
Yeah,
Okay.
Mr. Albert, hi.
Yes, according to the patch trial, they're going to use estradiol patch to replace LHRH injections. And apparently the results shows that estradiol is quite good to replace LHRH. And at the same time, we have better bone health and also cardio health. What do you think about using estradiol?
Yeah, hi, Mr. Albert. Thanks for your question. I think we have used, Professor Azad from UM has used this patch in the past and used it for a couple of patients. The thing that we worry a bit about estradiol is because of the cardiac toxicity. So we have to be careful in terms of embolism. It can promote some form of embolism. So we have to kind of look into that as well. And right now, it's still not really in the standard of care yet. We're still using LHRH. We also have to understand that a lot of the studies that have been done, we talked about combination therapy just now, LHRH with abiraterone and with chemo, looking at the survival. And then we also looked at the sequencing as you progress from castrate sensitive to castrate resistant. All that has been done with LHRH analogs, you see. So all that is going to be put into question mark if, let's say, the primary treatment changes now into estrogen-based therapy. So what happens with combination therapy? What happens with sequencing? All that is going to be a question mark. Yeah. So I think whilst this may be an option for selected patients, whereby they're having a lot of side effects or where they may be high risk for side effects with LHRH, then this may be one option. But I don't think that it will be like the standard of care. I think we will still be looking at LHRH analogs. Of course, we have the LHRH antagonist as well, which again is available in Malaysia, Digarelix. But with the antagonist, the problem is because you have to come for monthly injections. And of course, it's a little bit more, it's quite a bit more costly compared to the LHRH analogs. But I think LHRH analogs are here to stay. So you're looking at maybe a case-to-case basis, Mr. Albert?
Yeah, but I'm thinking about this transdermal estradiol. I don't think it goes through your liver or anything. It's just a patch on the skin. And well, I'm thinking of the cost implication. It's so cheap. One tube of estradiol is only about 80 ringgit, and it can last you for a month.
Yeah, side effect is one thing, but the other thing, of course, is cancer survivorship, you know.
Mm-hmm.
So we want to make sure that whatever treatment that we're giving gives you good cancer survivorship, many years that you can enjoy, not just good quality life, but also you're talking about life prolonging drugs, you know. So unfortunately, we don't have very robust studies. Like this was just one study, and then you need, I think it will be a while more for us to have sort of a lot more robust studies in order for us to evaluate in terms of cancer survival when you use drugs like this. Yeah.
Okay. Thank you.
All right. Any other questions, please? I think what it is, you know, just now we didn't have time for those old timers. We just got we cover a few of the new fellas. So I know that some of the old guys have a lot of questions or have a lot of development. I think today is quite rare, I can tell you, in all our support group meetings, that we have two experts with us. And okay, anyone who wants a question, just if you know how to put up your hand, if not, just unmute yourself and shoot. You'll be noticed. Go ahead, please. And anyone? It's as I said, it's very rare that we have
Mr.
Dr.
Kwan.
Silva and then
Mr. Kwan.
Okay, go ahead. Go ahead, please. Go ahead. Hello? Yeah, go ahead. Chua Sing, go ahead.
Hello?
Chua Sing, yeah, go ahead.
Hello. Okay, this I went on my visit to the onco was on the July the 8th, and my PSA reading for this July the 8th was 0.94, right? But my earlier PSA was 3 months ago was 0.68. Do you? I would like to ask this Dr. Sivalingam whether this rise is significant and whether it kind of requires further investigation.
I think, Chua Seng, I think you should give your background first. I think Chua Seng was diagnosed of quite advanced prostate cancer, I think about 3 years ago, and he went for chemo. And I think you have metastasis to the bones as well, right? And you went
yes, about 6-7 spots.
And together with now you are after chemo, you still went for Lucrine, yeah, Lucrine jab, yes, okay. But no Abila, you just went for Lucrine, and now after how many months your PSA just went up, and from what is the lady?
After almost 3 years,
After 3 years, your PSA start climbing from what?
Actually, my lowest score was PSA reading was 0.4. You started with, I mean, in the 2001-8.
Yes.
And in 2001-8, somewhere around this August or September, it was something like 500.
Yes. And with bone mats, and your Gleason score is 4 + 5, right?
No. It's 3 + 4.
Oh, 3 + 4, very good. And then you went for docetaxel 6 round, right?
Yes.
Yeah. Okay. And now the lowest level is 0.4, right?
0.4.
And then slowly climb up to 0.68.
Yeah. I mean, over the time, over every 3 months, the kind of 0.4, 0.4, 0.4 something, 0.5 something,
Yes.
0.68. Then the latest was 0.94.
In the period of how many months? From 0.68 to 0.9? 3 months, I think. Is it?
Yeah.
3 months. Okay. Chua Seng is our committee member, serving both Malacca and JB. He was my classmate in MU. He was taking maths and I was taking geology. Yeah. Okay. All right.
Right.
You're directing a question to Dr. Silva. Dr. Silva, okay.
Yeah, sure, Ken.
I think his question is when do you think that he should go for some other addition? You know, at what, I think what level, I think. Yeah.
The last last visit, the doctor, the onco, the kind of they saw me was Professor Linda. And she said possibly we should look at the next reading before we decide.
Okay.
Yeah. Okay. Thanks, Mr. Chua Seng. It's great to see you and meet you. And yeah, good question actually. Because you were diagnosed with you diagnosed about 3 years ago, right? You were saying 3 years. Yeah. Okay. So the initial therapy that they gave you was LHRH combined with chemo. I suppose you had a combination therapy, right? Yeah. So number one is that, of course, you need to make sure that you continue with your LHRH. It's very important that you continue with LHRH. That's the first thing. And then secondly is your chemo seemed to have a good response. Your PSA dropped down to an idea of 0.4. It's been quite stable over the last 3 years. Yeah. So that's actually quite good. And only now it's starting to creep up again. Now, there are 3 things that we look at. One is PSA progression. So what you're having now is PSA progression. From 0.4, it's gone up to 0.6 and then 0.9. So definitely the PSA is progressing. Secondly is we look in terms of symptoms, whether you have some new symptoms that you're experiencing now, which you didn't experience before. And the third thing, we look at radiological progression, right? So whether there are, let's say if we do any sort of imaging, are we seeing some new lesions which we didn't see before? Because I suppose after the chemo, you may have some lesions which may have disappeared or regressed, and then now you're seeing some new lesions. So we talk about radiological progression. So these are three criteria that the oncologist will use to decide for the next line of therapy. So if you look at sequencing, yes, certainly there is a role for abiraterone or even enzalutamide after once you get progression after chemo, right? So this is something that probably they will discuss with you as well. But it looks like you may require the next line of therapy from what you're saying. Yeah.
Yeah, that's what this Professor Alinda was exactly what she was saying. Because we shall look at the next reading and see, and then decide.
The question is timing, right?
Whether the increase continues or something like that.
Yeah.
So.
Okay. Can we move to another guy? Anybody? Any question? Because
I would like to
these
add a little bit.
Okay, go ahead, Chua Seng, please.
Yeah, my the symptom that I have that I get actually is the occasional. I mean, it has been with me all this couple of years. Occasionally, kind of a little bit of a little bone pain, on the ribs, and sometimes it's kind of on the sternum, which I had some and at the back. I think those are places where I have some possibly some cancers, my cancer spots.
Yeah. So that's the other thing. They also will check in terms of to see whether you may actually, in addition, require any bone targeted therapy. So that is the other thing that they may actually look at, the oncologist, right? So now we have denosumab, which is very good, which targets the bones as well. So this may be something additional that they may consider.
Yeah. Okay.
Thank you, Dr. Steve.
Okay, I think next one. Why not we try Mr. Chui Tak Wai.
One thing.
Yes,
one
sir.
thing. There are a few questions from the notes. Can you please read out?
Joe Volachari. Okay. All right.
From Jen Chan.
Huh? One is Sasi. Okay, I read Sasi one from the bottom. Dr. Silva.
Yeah, I saw that. Maybe I can answer that. Yeah.
Okay, go ahead.
Yeah, that's a very good question actually from
okay, go ahead.
Sashi. Yeah, because this is a question that we are often asked because of the financial constraint.
We read out the question first, Dr. Silva, because I think the rest. Okay, this gentleman has ochiectomy, that means has the testicles removed in 2019. He said, will you recommend for this for those who have financial constraint instead of taking Leucrin? Okay, that's it.
Yeah. Okay. Yeah. So I definitely LHRH is not cheap We all know that each dose costs about 1,000 plus, and then you're taking it every 3 months, and this is something that you're going to take literally lifelong. So there's always been a question of whether you can do an ochiectomy. There have been quite a number of studies that have been published over the years about the rising FSH after ochiectomy. FSH is one of the hormones that's released from our pituitary gland, from the brain. And after ochiectomy, one of the problems that has been postulated is that because of increasing FSH, there may be a higher risk of cardiovascular toxicity or cardiovascular morbidity. So in other words, they have looked at patients who have undergone ochiectomy. And then in those higher risk patients, that means you already have some risk factors for cardiac morbidity. This may be increased. Your morbidity may be increased after an ochiectomy. So that is why there are quite a number of people who now are proposing not to consider ochiectomy, that maybe you should just stick on to the LHRH analog. But many of these studies were done by proponents of the LHRH antagonists. That means it was actually sponsored by the company that was dealing with Digarelix, mainly because Digarelix is the only one that doesn't really increase your FSH level. Even with the LHRH analog, there will be some increase in FSH level, But with Digarelix, you may not get that. So that's why they were advocating in patients with cardiac morbidities, the antagonist may be the best option. So that means you already have underlying cardiac problem, then you may choose to take the antagonist. But again, as I mentioned, the antagonist is not cheap either. So nowadays, less and less we are advocating for orchidectomy. But in those patients who don't have cardiac morbidity, then I think it shouldn't really be a problem. That means if you don't have risk factors and you're not really having cardiac problem, even if you do orchidectomy, I think should be okay. It should not affect you.
Yeah.
Yeah.
I actually, my cousin who is 90 plus, he doesn't speak English, or he'll be here. So he's 90 plus, but he's getting hormone refractory. So unfortunately, one urologist who are not really in the mainstream of prostate, even though he said, no, after this, you're going to go for, the best is to cut your balls off. So I thought there is not much difference because orchidectomy, after you have Leukrine and it failed, does it improve? If a Leukrine fail, you just have orchidectomy?
Well, the thing is that there is a small percentage of patients who may not respond to LHRH analogs, so in that group of patients, you may see some benefit of the orchidectomy. But if you, I mean, that was the whole sort of logic of doing the orchidectomy in those patients who don't respond. But if you have a patient who have responded for a while and then the PSA started rising, then this is due to disease progression rather than non-response to LHRH analog. So in that kind of case, then doing an orchidectomy may not really change the outcome.
So there is a chance that he improve. That means hopefully
well there's a very small percentage that may not respond to it. Yeah, but there is an option of antagonist. So you can actually try an antagonist instead of going straight to orchidectomy.
Yeah, I mean, he can go to
antagonist and see whether Digarelix, and then you could try that instead of going straight to an orchidectomy.
What is the difference in efficacy between Digarelix and Leukrine, for instance? I mean, or any other? Is it slightly better or what? But mind you, the other one is monthly, right?
Yeah, Digarelix is monthly. The only thing is one benefit, as I mentioned, like in those patients with cardiac problems, because you don't get much increase in FSH level, so therefore it protects in terms of cardiac protection is better, Digarelix. Yeah. The second thing is that the response is faster. With the LHRH analog, it takes a while. It takes about 3 weeks sometimes for you to get the drop in your PSA. And then usually sometimes you worry about the flare. So you have to start the patients on Casudex and so on. So if you have a very symptomatic patient and you want very quick relief, then the Digarelix may be the way to do it. And especially like if you have patients like sudden onset of paralysis. You have cases like that, they have very severe match to the spine, for example, and then they have a sudden onset of paralysis. This is how they end up in the emergency. Those patients need immediate treatment. So in those cases, in the past, what we used to do is chop off the balls, do the orchidectomy, is it? But an option is now to give Digarelix to bring down the PSA quickly and shrink down the mets, Yeah, so that's where Digarelix can be useful.
Well, okay. I there's another question. This is from Jen Chan. Is it? How often should PSA blood tests be done? Yearly or longer interval? I last done in 2018, where the reading was 1.1, and it was also 2016 also 1.1. Now, this gentleman, I don't know what is his background. Mr. Jen Chan, are you still there? Jen Chen. Mr. Jen Chen, we don't understand what you are trying to say, because you have a low PSA and then you ask us how often you should do it, is it? We don't know whether you have prostate cancer or not. We are not very familiar with you. Okay, now if Mr. Jen Chen, can you unmute yourself and ask the question? Oh yeah, you are there. I can see your Jen Chan, Jen, Chan. Jen Chan, you posted a question. Can you unmute yourself? Jen Chan. No. Okay. Never mind. I thought I saw, if not, then I move on. There's one gentleman I like to see, to hear is Mr. Chui. Mr. Chui. Can you unmute yourself, Mr. Chui? Mr. Chui.
Yes, I am here.
Okay, I think Mr. Chui, his original PSA was very high on diagnosis. I mean, he is a recent, and he, I think 1008, Mr.
Yes.
Chui? Yeah. And okay, you're on Firmagon.
Yeah.
And is there anything that we can help you, Mr. Chui? I know.
No, well, thank you. Anyway, I just was diagnosed in early this April, and I started with Firmagon for 1 month. Then we went on to Lucrine. So
Yes.
the blood test showed from 1008, it came down to 109. And the one last day done in June, end June, showed that it was down to 7. So we had a discussion in the family and decided that maybe we should try Firmagon for a start and see what happened. And before we want to go further, the rest we just wait for the doctors to give us the advice.
Yeah. So, and you don't have any heart problem, huh?
No problem.
Okay.
I mean, that's the whole trouble when we say no problem, because younger days we are all very athletic. I mean, we play a lot of sports, exercise a lot. So we never take care of our body anyway. We thought that, being able at least we are doing well, I think. But little did we realize that actually it caused a lot of problem.
Mr. Chui, you heard from Dr. Murali and Dr. Silva,
yes,
that if I'm not wrong, that in this modern age, that because you have bone mets as well,
yeah,
so it is better to add on in additional to just only Lucrine, something else. Either you go for chemo or you go for another targeted therapy like RB and so on. Yeah.
In the blood test, in the last blood test, the what you call the alkaline also came down. That means it's a little bit contained. So in the meantime, we will just wait for the next blood test, which is due on the 16th of this month. We will check and see what is happening before deciding further. But in the meantime, because I'm waiting for the result of the amplitude test, I'm still waiting to find out for oncology. Much as I am anticipating, I don't know what to do. But at least it is contained, then there's no worry in the meantime for a while.
Contained means what?
Contained means it has dropped. It has come down.
Oh.
The
Well,
reading has come
the
down.
PSA will drop down, but never mind. With the other one, you just have a discussion with your oncologist, Muthu, right? Yeah.
Yes.
Yeah. Okay.
Thank you.
I think both Dr. Silva and Dr. Silva and Dr. Murali know who Muthu is in the oncology department. I think. Yeah. Okay.
Yes. Thank
All
you.
right. All right. Who else want to ask any question? Please.
I think
And
there's
I say,
Mr. Kwanse, I think there's a question here from a gentleman by the name of Kalidasan.
Okay, go ahead, Kali.
Yeah, actually Kalidasan, he sent a message lah. Yeah.
That's right.
Yeah, so Kalidasan, I've actually seen him. I've seen him.
okay.
Yeah, and diagnosed him with prostate cancer. He had only one lesion, and the biopsy came back as a 3+3, right? So this was more than a year ago. And I discussed active surveillance with him. His PSA was less than 10. I can't remember offhand what was his PSA. Less than 10, he was asymptomatic, and we discussed about active surveillance, and he has been on active surveillance. There's not been much PSA progression. And I did a repeat biopsy 1 year later, the exact same spot, 3+3 again, right? So there's no progression in the grade of cancer as well. In terms of volume as well, no progression. So it's been stable for him. But as I mentioned just now, sometimes, it's not easy to be on active surveillance, right? Because you know that you're harboring cancer and you're worried that it may the grade may change, that it may progress, and that you might miss the boat. So I think this is certainly the thing that he's battling with as well. And I did discuss with him that because he's young, there's no doubt that he will need treatment. And it's just a matter of whether you do it now or you do it later. He's only in his 50s, by the way. So he's a very young gentleman. And I think active surveillance is mainly, in his case, is to buy time. He will definitely need treatment. I think the last conversation we had was that yes, if he is already prepared for treatment, then he should go ahead and get it done. And I would certainly suggest that he has a radical prostatectomy done. So I think he's just asking me, in terms of what type of treatment is right for me. So so I think what we discussed before, Mr. Kalidas, is still the same. I think if you're planning for treatment, the right treatment would be a radical prostatectomy.
Okay.
Mr. Wong, Mr. Wong.
Yes, carry on.
One question.
All right,
I
Mr. Chui.
actually want to ask a little bit of for my friend, my badminton friend who has been playing for my ex-colleague. He has been getting a blood test result of PSA 20. What are his chances of getting into prostate cancer?
Very high.
Very high, even at 20.
I don't know. You ask the two gentlemen. What say you, Mr. Murali?
Mr. Murali.
For change. Mr. Murali.
Yeah, okay. How old is your friend?
71.
And is this the first time he's done his PSA?
Well, he has done a few in the past. Again, like I said, sportsmen don't think they are sick anyway, so they don't go and check. Even for me, 72, my lifetime history, probably a blood test maybe 3 or 4 times only at the most.
Of course, PSA can go up for many reasons,
Yes.
infection, big prostate. But of course, anything more than 4 is already the red flag for urologists. It's an international red flag, like how we have white flags here. PSA more than 4 is a red flag.
In Australia, it's 0, In Australia, it's 0. Australia, the permitted level is 0. My friend at 0.2. Also worrying.
Yeah. So definitely your friend should go and see a urologist and get checked out.
He's so worried that I think he's hiding away and then I'll expose himself to go and check, holding on. It's about 2-3 months since his blood test is done anyway. So there's a very high chances. I will tell him. The sooner the better. Thank you.
Okay. All right. We have another question on this Albert asking bipolar androgen therapy, BAT, where high dose of testosterone is given together with ATT to resensitize AR resistance. What are your thoughts? Dr. Silva, go ahead.
I actually don't know much about this. I think maybe
it's a very.
I don't know whether Dr. Murali has got anything to say.
Yeah, Dr. Murali, have you heard of BAT? Other than the flying fox.
Yeah. Yeah, this is not standard of care. These are experimental therapies, which are interesting, but we really need a lot more data before we can say things like this, Yeah, a lot more data. Yeah, it's interesting, But we all know that the treatment of prostate cancer is to take away your hormone, take away your testosterone. And this is the opposite way, to give you some testosterone. So it's interesting, but it's certainly experimental and should only be done in the context of a clinical trial.
Yeah. It's also, you're risking your life, of course. If you volunteer that and suddenly you inject testosterone and then, your cancer start to metastasize or getting worse. That's terrible, isn't it? Yeah, indeed. Okay, anyway, any other fellas who want to have a shot? As I said,
one thing, Chan Cheng Kiat raised his hand. Can you give him a chance to talk?
Go ahead. Our veteran Chan Cheng Kiat, go ahead.
Okay, Dr. Silva, I was your patient in 2012 when you were still in HKL, and you did the robotic surgery on me. So now after 9 years, my PSA is still maintaining at 0.01.
Oh, very good.
Okay, now my question to you is there, what is the possibility of recurrence of the prostate cancer on me?
Hi, Mr. Chen. Hi, how are you?
How are you?
Yeah, I think when we talk about recurrence in prostate cancer, it can actually occur at any point of time. You know, there's no timeline to say that after a certain number of years or X number of years, everything will be okay. Unfortunately, that's not the case. We do have late recurrences as well. Most of the time, these late recurrences, they may be local recurrences for some reason. But looking at your progress so far, touch wood, I think hopefully we are looking at long term without any recurrences. But the whole point of what I'm trying to say is that for any prostate cancer patient having undergone radical prostatectomy, even though your PSA may be at undetectable or very low levels, you must continue follow-up lifelong. Let's put it that way. You know, it has to be followed up lifelong, because we have seen that even after many, many years, there may be some small PSA recurrences. But God willing, I think you will have a long life, and whatever it is, prostate cancer will not shorten it. You know, let's put it that way.
Well, Cheng Kiat, I would trade my right arm for that, man. Anyway, the other thing you should do is that be grateful to your urologist who can give us such a wonderful operation.
No, and Dr. Murali as well. Dr. Murali as well.
Both of you.
Both of you have done a wonderful job actually on me.
Yeah.
So,
I mean, that is a great news. I mean, that's why people go for surgery. There's a hope for cure. And I think in your case, I think you can just assume that you are cured, because Marcel, do that and enjoy yourself. Okay. Another guy? Any guy?
One thing, Ravin has a question. Has it been answered?
Ravi again. Hey, Ravi, go ahead, Ravi. Ravi, do you want to come in, Ravi?
Yeah. Dr. Murali, can I ask you this question, please? I had SBRT 2 years ago, and then I had a relapse, and I'm on hormone therapy now. But my oncologist was strongly advising me to go for salvage robotic surgery, which of course I'm still debating whether I should or not. From your experience, how difficult is salvage operation? What are the risks involved? And would you personally recommend it?
Can I ask you, what was your PSA and Gleason score?
Gleason
before
score
the
I'm 65 years old. Gleason score was 3+4, and my last PSA was 3.7.
The PSA before starting radiotherapy?
Before I started the SBRT was 13.
Okay.
13.
So by SBRT, you're talking about external beam radiotherapy.
External, yes. Five
How many days did you have it?
I had it on alternate days, 5 sessions.
Only 5?
5, yeah.
So yes. That's really, hypofractionated SBRT, okay? Yeah. And then
I had it in Singapore.
I had it in Singapore. I see.
And because I live in Johor Bahru, it was more convenient to go to Singapore.
Was it combined with hormonal therapy?
No, it was just SBRT. That's all.
And then after that, when the PSA started to go up, they added on.
It was fine. After 2 years, I went for a checkup last December, and the PSA score started to move up. Before I went for the hormone therapy, it was 3.7.
3.7. Did they do any PMSA PET scan for you?
Yes, I did.
And what was the result?
PSMA confirmed the presence of a tumor, a cancerous tumor.
Only in the prostate and nowhere else?
Yes, only in the prostate, non-metastatic.
Okay. So in terms of, so you're a guy who's got prostate cancer only in the prostate, nowhere else.
Yes.
You could have chosen radiotherapy or surgery, but you chose radiotherapy.
That's right. Yes.
So you had this SBRT, which is a relatively new form of radiotherapy, and now you've got a recurrence.
Yes.
So
it's only about 4 years ago, or 3 years
That's
ago.
right.
Two-
Yeah,
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 3 years.
yeah.
3,
Yeah.
1,
So
8,
the-
yeah.
So the question is, after you have radiotherapy and you get a recurrence just only in the prostate, what to do about it? So the majority of people, the majority of men will only have hormonal therapy. That's the majority. Okay? In a very few people who are young, people who really want to talk about cure, they're very, very fanatical about cure, they might decide, look, I want to have something else done about this prostate, about this cancer in the prostate. So your options are to go for surgery, that means remove the prostate gland, or go for cryotherapy. Cryotherapy is where they put in probes and freeze the prostate. Now, I don't know whether they do that in Singapore. I think Singapore has cryotherapy.
They do in Singapore GH.
Yeah. So both options were available to your oncologist. That means you could have said, look, you're young, you really want a cure. So your best chance of cure is go for that prostate cancer. So he can either choose surgery or cryotherapy. So did he kind of tell you which would be a better option, or was he very insistent on surgery?
No, the radiation oncologist was of the opinion that cryotherapy would be a better option for me.
Cryo.
Yes. But I'm told it's not available in KL.
No, not available here.
No.
So the option was to go to Singapore, but because the
I
border,
think the Singapore one only started about 1 or 2 years ago, right? And I mean, my view is that because I have been to cryotherapy, I think my view is that you want to cryo, you have to go for a reputable center. I mean, really, with a past record, because it's a quite a sensitive one. But of course, nowadays the modern technology, you will not get a fistula and all that. In the olden days, when I talked to Dato Silva, who told me that you go for cryo, and all the other guys are shouting, no, don't do that. You will get fistula. And then I was really half-hearted. Then I check it up and I found that MD Anderson in Houston, they said this is a very rare case that you get all these side effects. Then I have the guts to go. But of course, it costs a bomb.
If you were to go for cryotherapy, like as Kwan Sing says, if you were to go for cryotherapy, you must go to a reputable center. That means you must ask them, look, guys, what is your results? How many cases have you done? What was the complication rate? What was the success rate? So that's the questions you got to ask when you go for cryotherapy. The same thing you got to ask for surgery. If you come and see the surgeon, you must ask, how many cases have you done? What is your continence rates? Now, in Malaysia, very few of us have done surgery after radiotherapy. I think I've done only one case, somebody who had radiotherapy and halfway he stopped it. And then later the cancer recurred and he wanted to go back to the radiation oncologist and she said, no. Once we have given you radiotherapy, we cannot give you some more radiotherapy. And I did that case. So our experience in doing salvage surgery after somebody who has already had radiotherapy is very small. So if you come and see us, we will quote what is the results from international centers. Now, the international centers, their continence rates, that means their continence rate is only 50%. This is from the best centers in the world. So if you come for robotic surgery, your continence rate is only going to be about 50%. So you've got to take that into consideration. Yes, you may cure the cancer. Some guys just want that cure. They don't even mind if they're a bit wet. Now, if you are in that category, yes. With the robotic surgery now, we've got a new technique. It's called a Ritzius sparing technique. And the results coming out from Europe, where they do Ritzius sparing surgery for people who've already had radiotherapy, is the continence rate is better than 50%. But you still can't expect the same kind of continence, that we get for people who have never had surgery. Like the Ritzius sparing technique, almost 80% of patients tend to get almost immediate continence after the surgery, which we never got before with the conventional kind of treatment. So you can expect a bit higher than 50%, but you cannot be patients. We have to tell you the risks.
What does the procedure entails, Dr. Murali?
No, the same. It's robotic surgery, but But the way we do it is not the conventional robotic surgery. It's a Ritzia sparing surgery. Ritzia
Okay.
sparing surgery, the advantage is you get your continence back earlier and you get a higher rate of continence. And that's why we do this Ritzia sparing. But for people who have had radiotherapy, yeah, we expect you to get better than before, but not the 90% or 100% continence rate that we get with people who have not had radiotherapy.
Yeah.
Thank you, Doctor.
Okay. Any other questions? I don't know whether Dr. Faisal Woon is here or not. Dr. Faisal Woon. I don't know. I cannot see his name, but anyway, if he's here, just shout. Anybody who wants to have a chat or ask a question before we close it up? We are about half an hour over time. If not, I just close the whole thing up. Hello? No more? Okay, if it's no more, I just sum up and then I'll thank everybody. Okay. Actually, we learned a lot. We learned a lot this session. Of course, we are very fortunate. Of course, we have a lot of experts here. I must acknowledge the presence of Dr. Heng also. She's with us, perhaps in another group, because what we do is that when there's more than 100, it overflows to our YouTube group. And Dr. Heng said she's in, but couldn't get into the Zoom group. So Dr. Heng is in or was in, whatever it is, because we can't see them, So today's present is quite a lot. I think at a peak time, easily 100 over, but we don't know how many over the 100 because we have no count in the YouTube group. And we learned a lot from Dato' Silva, and in the sense that I was shocked that over 50% Malaysia on diagnosis is in stage 4. I thought the latest I had was 60%, on diagnosis was 3 and 4. But 50% stage 4 is very frightening. So what is it due to? I think I happen to be in a urological trust, and we discussed this and then we find that one of the main reasons is maybe lack of awareness of prostate cancer, thereby very lack of testing. So the urological trust is trying to rectify it, and we have some sort of what do you call KPI, saying that in 5 years we are going to reverse to the more or less like other countries. Instead of 60-40, 60% diagnosis and then 60% 3 and 4, we should aim for 40%. Okay, and in 5 years we hope. Now, how do we do that? Of course, the Urological Trust is very fortunate that we had a donation of 5 million raised by Dato' Sri Nazil, and that will be spent in that cause. And the first step is to educate the GP so that they are more well-versed with prostate cancer. And Prof. Ong, Jasmine, and all this, they are in the process of designing a module for testing, for educating the GP. And they are putting their heads together, and then they are trying to roll out the program to educate the GP. And then from there, we are also having arrangement with institution like Prostate Cancer Society, National Cancer Society, to have a very cheap PSA testing. I think we can negotiate down to about 13 ringgit per test. So we will subsidize the cost of prostate cancer tests, PSA tests. So in a way that we hope that we have a lot of coverage so that we can spread awareness and have early detection. So that will, what it is that we will increase the amount of detection of early prostate cancer. That means the grade will be lower, and then hopefully, and as long as when we are aware of prostate cancer, I think Unlike now, or people like myself, before I got prostate cancer, I didn't know what is prostate cancer, until one day I walked in because of my annual physical, and they say, your PSA was very high. But anyway, so what it is that we are going to address the issue, and hopefully in 5 years' time, we will try to improve that with big money. So, and that is meant for awareness and testing. So that is very good. Anyway, we also learned that, a lot of things that we learned from Dr. Murali as well, about all these combinations and so on, and Dr. Silva, and then we saw a lot from all these view graphs. And anyway, the last thing is that I would like to move to thank Dr. Silva for the very informative talk. Who is that? Okay, I don't know what is that. Okay, now somebody posted something, but anyway, not important. But
very important. Membership.
Oh, membership. Okay. Okay, I tell you what. Okay, I pass it to Stephen Kong. Can you talk about membership again before I proceed and conclude?
Yes. I think, for those who have not joined the Prostate Cancer Society, I've already attached here, print screen is the form. However, if you are not in any of our chat group, can you please PM me so that I can send the form to you? My number is 019-2247-917. It's good that you're joining the Prostate Cancer Society. As I mentioned earlier, it will give you more benefit when joining the society. Thanks.
Yeah. Okay. For those people,
Mr. Wong.
Yes.
That's a question that Mr. Tu Teng Hong put up for Mr. Murali. He says,
what do you say? What do you say? He
said, no, actually, he's just saying my PSA has dropped from dropped to 0.02 in the last 3 reading on Zytiga and with prednisone, and 3 monthly Leucine. What is your assessment with advice to future maintenance? Thank you.
Well,
switch on medication.
Well, Mr. Tu is from Penang, and he went for the RB and neuroparin trial, and then they found out that he was in a placebo arm. So whatever the benefit came is that he benefit that he gets Zytiga for life. So now he's on Zytiga. So I think, even for layman, I don't know, unless the expert thinks differently. he just keep on to Zytiga, is doing well, and he responds Zytiga, because at one point we are so worried that, his PSA will keep on rising. But now I think, as far as I know, and I talked to him recently, just a couple of days ago, his PSA is very well maintained. So I think just monitor himself. The Zytiga is, after all, you can get free Zytiga, and Zytiga are good branded stuff as well. So basically he has Zytiga itself, the expensive one. Anyway, I think that's okay. That one I think is easy. I think I just want to say, all those guys who feel that they have something to discuss with us, can you please stay back after we disperse with the speakers and the professional staff, okay? I want to continue. Actually, Dato Silva, I want to thank Dato Silva for his time and for preparing all this, we have been all the time thinking, how do we fit Dato Silva in? Because we want, now this is our second national support group. I think it is very, very, very good that we have him to join our support group meeting. And Dato Silva is actually my neighbor. He lives about 1, 2, 3, 4 doors away, all right, in Bangsa. And we are very close together. And we know him, I know him from nearly day one, So, and he is very passionate in this. And I remember I first met him He was really, I think, was the president of the Urological Society of Malaysia, and he was a president, and the professional one, and he was very anxious to start some sort of big support group, and then of course we debated to form a society, and in which he was our first advisor. Okay, and I feel that, you know, today I learned a lot, and I really certainly enjoy it. And if you can unmute yourself in our usual way, we would like to thank Dr. Silva and also Mr. Murali for fielding the question, and also answering a lot of questions during our support group meeting, especially to the new ones earlier on. And I also like to thank Dr. Heng, who will be our next speaker I think it's on the 3rd of September. He will be talking on SBRT and new forms of radiotherapy for treatment of prostate cancer. Dr. Heng is what you call a physicist, specialized in radiotherapy. And he works very closely with, of course, all the oncologists in Sunway. And I'm quite sure she works with Dr. Murali and Dr. Silva as well in the Sunway Hospital. Anyway, I think we are coming to the close, and if you can unmute yourself, we'd like to. Somebody disturb again. No, that one is okay. Okay, we would like to say thank you to Dr. Silva and Dr. Murali, and can you unmute yourself, and can we give a very good round of applause to both of them?
Sure.
Thank you very much.
Thank you. Thank you.
Thank you.
Thank you so much.
Thank you. Thank you very much for the kind invitation.
No, we really enjoy it, yeah.
Yeah, it's a very long session. Too long.
Too long, no, nothing is too long.
Too long.
Who's the guy who said too long?
Colonel Allen.
Alan, who is Alan? Colonel Alan, Colonel, you have no patience lah.
No.
You're fellow army guy, man.
No. I just had my jab, so I get tired very quickly. I'm not sure why.
Oh, that is good lah. Myself also, when I jab, I got very tired. I think is one of the good sign. You got a real one. You got a good one, rather than empty ones.
I got Sinovac.
Oh, Sinovac, sir. Okay.
Guan Xing.
Yes, sir.
I think we have already spent more than 2.5 hours. I think we should stop. Otherwise, in our next Zoom, nobody will join us already. Everything
No. Okay. All right. Unless you guys I think Stephen Kong would like to do some other work, isn't it?
House cleaning.
He's a house husband, I think.
How to clean this house, the PCSM house.
Wow.
Okay, right?
Okay.
Thank you very much.
Yeah, and
okay,
right?
Thanks a lot. Thank you, everybody.
Okay, thank you.
Bye.
Nice evening, and see you next time. And also,
thank you.
One more final thing. Any other new guys who want to join in a small chat group, you know, normally this is the idea from our welfare subgroup. Albert, Danny, and I think Raymond, myself, and so on. We are in a what you call a welfare subgroup. I think we can entertain every time about 5 or 6 new patient or even old patient coming in. And then we have a very good small meeting with them. We try to do it once a month or once every 3 weeks. Depends on the demand. If you need it, you just, talk to Albert, me, or Danny, or Stephen Kong, and we'll try to fix you up, okay? All right? Okay, thank you.
Thank you.
Bye-bye.
Bye-bye.
All right. Okay, bye.